Good morning. Good morning, everyone. I was explicitly asked to tell you that it's not allowed to take your coffee inside. So after the next break, I think we have to leave our cups outside. I think they did some new upholstery on the chairs, and we all got like new audiovisual equipment here. So let's take care a little bit of this great room. But for now, enjoy your coffee. And I would like to welcome you at the 37th CARIM Symposium. And for those that have paid attention, you will see that this is actually the first CARIM+HVC Symposium. And we paid particular attention that we put some emphasis on this today, because last year, as all of you must have noticed, we were able to merge CARIM and the Heart and Vascular Center of our hospital, in which we could seamlessly align the arrowheads of the HVC, which are cardiovascular thrombosis, metabolics and heart failure, with our divisions of blood, vessels and heart into one big unit, which is actually an inspiration for the MMC and the FHML board, because this actually gives them hope and inspiration for the next decade, because they want to organize the whole university hospital like this. This led to a fantastic joint annual report, as you see here. Also, again, a beacon of inspiration for our faculty and hospital for the decade ahead. And on this slide, you can see 193 staff members of our joint institute now. I had them counted by ChatGPT because it's difficult to estimate the amount, so ChatGPT can do that as well. And here you can see the basis of the next 10 years of hope and inspiration. So at this moment, we thought ourselves, CARIM+HVC is ready for the future, good to go, but then came our external review board. And this happens one in every 6 years, and which is tremendous effort for our bureau, and of course all of you helped really well in establishing all these reports. And our expectations were high, and we did exceptionally well, although there were some minor issues. Here you can see the external review committee. Many of you have met them and actually discussed CARIM+HVC with them. And you can see from left to right the secretary, Roelinka Broekhuizen, then Professor Meijer from King's College, Professor Sipido from Leuven, Professor Buller, the chair from Amsterdam, our PhD member Jamila Goedegebeur from Leiden, Professor Uitenboogaard from Groningen, and Professor Roos Hesseling from Rotterdam. And Professor Rossing, due to personal circumstances, could not attend, but he was online at the meeting. And the first slide I showed, the external review committee, was CARIM's mission statement. And I think it's a pretty cool statement. We want to be happy in our life, having a meaningful life, doing cool cardiovascular science with nice and friendly people. We want to communicate this in top journals. And the best thing we do at CARIM is to identify young talent at an early age, and we make them grow up within our institute. When they go out, it's fine, because then we have ambassadors for CARIM. When they stay inside, we have the best researchers in the world at a very cheap way, because we don't have to buy in very expensive groups. And for this talent program, we have developed a fantastic tool, and that is the Harry Struiker-Baudier Award for Talented Academics. And welcome, Harry, here in the public, you're here today. And the HS BAFTA, and we have a lot of fun doing this, and many PhD students and postdocs and pre-PhD students we have sent over the oceans to very famous institutes to have between 3 or 6 months or even more than a year experience, and then come back to CARIM. But I hadn't even started to reading the first sentence, and then the external review committee already said, stop, this is not good enough. What are you doing here? You need to be, or to become, the best in Europe. And then we said, well, sorry, committee, we're not from Amsterdam, we're here from the south of Limburg, and we're used to do excellent things in humility. And so we think we do things really well. And then they say, well, now you really have to become the top of Europe. And then we say, okay, so maybe we'll make that our mission for 2026 to see if we are not already the best in Europe. And I think there are some ideas that we are. We had an analysis in the Netherlands Heart Journal in 16, that's like 10 years ago. And that was originated from the Dutch Heart Foundation by André Klaassen, who is senior author on this paper, in which it stated that Maastricht UMC has a very high citation score and a strong research profile, and at least one of the top institutes in Europe. But we're going to measure this, and we're going to do this in two separate ways. We're going to ask each PI who is, in your specialty, the institute that you count with, that you listen to, that you follow in Europe. And based on that specialty, we will analyze that institute and see how that institute ranks in comparison with us. And secondly, we will just do a regular keyword analysis, just leave it free, and for all Europe, all institutes, see who comes out the best within the top 10 publications of a specific keyword or research area. And then those two ways we will compare and then make a ranking, and we'll just know that will be the best, because nowhere in Europe is there an institution that combines all three aspects of cardiovascular disease: heart, vessels, and blood. Many do heart and vessels, but the combination with blood is rare to find. So we will know that we will win in the end anyway. Then I'll report to you next year on the coming symposium. So we tried this already for CARIM to see how do we do with top 10, 5, 2.5, and 1% publications. And then we looked for cardiovascular disease. And you see that cardiovascular disease for CARIM is approximately half of its publications. The other one is more general, like internal medicine, all these kinds of journals. So in the world, between 19 and 24, that's the time frame of our external review committee this year, we had 286 or 69,000 publications, of which more than 2,000 were from CARIM, which is less than 1%, which I think is already impressive. But then when you go look for the top 25%, top 10%, top 5%, and top 1%, you see that the percentage of CARIM increases up to 3% in the top 1% of cardiovascular publications in the world, meaning that among all top 1% publications in cardiovascular research in the world, 1 in every 30 is authored by CARIM. I think this is amazing if you already realize that there are approximately 500 to 700 cardiovascular institutes in Europe alone. So I think with that already we show that we do a fantastic job within CARIM, and I'd like to thank you, of course, all here today for your output and bringing us so high up the academic ladder. So next year we will ask all PIs to make a list of the top 10 institutes that they think are important in their field. And with that list, we will start doing our analysis. So this request will arrive pretty soon. So these are our PIs at this moment. And the moment I showed this to the ERC, they also very much disagreed with this system. Our PI system is already under pressure. It has been actually for some times, and not alone because the leaves are dropping in November 25 because of our autumn. Also because the ERC said to us, or maybe actually screamed to us, get rid of your PI system. It's not the good terminology, and you need to do something about this large let's say, representation of man in our PI system. So this is already the second time that this was like a big critique from the ERC. So now we decided to actually do something about this. So not only the leaves drop, but also this autumn the PIs drop. And so this is now an empty tree in which CARIM has to build something new. But we know that the PI ship needs to go, and we need to find a new phrase for that. So we decided to make this section leadership. because the PI, principal investigator, is actually somebody that is the main applicant on a research grant. So we use this term in the wrong way. And we also now found this opportunity to look at the big sections if there could be some independence from some separate specialties within this larger PI groups. So under the nourishing, always shining sun of CARIM, I now present to you our new section leader tree, which will arrive in the spring of 26. And you can look at this tree. You can see here the program 1. You can see program 2, program 3, program 4, program 5, and program 6. And we expanded a little bit. We got much more diversity in it. And if you then do the math, in 24 we had 21 principal investigators. Now we have 22, or we will have 22 section leaders. We used to have 90% male PIs. Now we have 64% male PIs, which is an improvement. But more importantly, the average age now drops from 58 to 51. I can't read it anymore. 51 years, and I think that's probably the best of everything. So this will happen in the spring. We'll inform you of all the names and the new program structure that we have within CARIM. We have discussed this lengthily within the management team, within the daily board, and with the respective PIs, and of course with the new junior section leaders. And already I would like to congratulate you with this honor within CARIM. But then again, so what we do with the PIs? Well, the PIs we already have, and you can meet them now here, because the PIs are actually the main applicants on these large grants that CARIM acquired in the last year. And you can see all the grants here above 250,000 euros. Daniel Moulin is not present on the internet, so I'm not sure how he did this, but there's no picture of him to be found, not in any archive. So we spent approximately a day of finding a picture of Daniel Moulin. Daniel, I'm not sure if you're in the audience. He's not, because otherwise we could have taken a picture of him. So, but that's the thing here. So this is very impressive. Thank you all for bringing us all this money. There's a second page, and there's also another page with acquired grants of under 250,000. And Marleen Gevenbroek, are you in the audience? She's not. Probleem met de auto. Okay. Because Marleen, it only would have cost you like €3 extra here to be on the picture page. So next time, get a little bit over this 250,000 euro. Then we have, of course, our royalty, and these are very important for CARIM, but also for the individual careers. These are the prestigious individual grants, for which we congratulate everyone here on the slide. Most of them you will hear today during this CARIM Symposium. Judith with the Vici, Bart with the Vidi, Yassin with the Mosaic grant from NWO. We have the Heart Foundation Dekkers for Elisa and Job. Sabine Veni, Uyen Veni, and Dylan Rubicon. And Dylan is not here today because she became a mother very recently, and also very much congratulations on that. And if you look at the key indicators of last year, with new contracts and grants of 10 million, an average CI that's of 2.3, so that's more than 2 times better in the world, with 3.6% papers in the top 1%. We now already, with these grants, and it's only November, have exceeded the amount of 15 million. So we're really doing good in CARIM. And although, I mean, we feel the pressure of the faculty, we have to cut costs, I think we are doing still very well. And I have at least big hope for the future of CARIM. A lot of people went up on the academic ladder also last year. You can see them here. Judith became a professor. Elhan became a professor. There's one more professor, Mark Spanerman. He joined CARIM also last year to make it complete. And then you see all the assistant professorships and the associate professorships. And we also today honor our visiting professors who are continuously inspire us by their visits and their master classes. And Kathy is here with us today on the third row in the middle. Thank you for being here, Kathy. And Peter Stenwinkel, he will receive an honorary doctorate in our 50th anniversary year of 2026 from this university. So I would like to ask you also to join those festivities at the end of January next year. My time was cut down by our organization team because they were pretty much bored by the long stories I always told in the morning. So I already come to almost my last slide. Yesterday, you got an invitation from our office to join CARIM SAM next Monday, and I keep on asking you, be there. It's really nice. It's a loose atmosphere. We have drinks and bites, and you can discuss science and life. So next Monday, be there at SAM. And then today, I'd like to then officially open our first CARIM+HVC Symposium, in which we have a very impressive lineup in the morning by our personal grants representation. We have also a very new initiative proposed by the CARIM Society. That's the Professor Reneman Young Investigator Award, and this will really be exciting. So be there to witness this. And then we'll have a very nice keynote lecture after the lunch about monkey stuff later. And then we have the Heart Foundation Dekker postdoc lectures. The Robert Reneman lecture by Professor Hart Markering. I'm not sure if he's already arrived. Yep, in the back. Thank you for being here, Henk. And then at the end, we'll have the CARIM Awards, and then we will go to Thyssen. And with that, I would like to hand over the microphone to the moderator of the first session, and I believe that is Christian Wouters.
Thank you, Tilman. So for this session, we are going through some of the successful candidates for the NWO Talent Scheme. And within the Research Council, I had the pleasure of also seeing at least certain stages of these proposals, and that makes me really happy to see them being successful in the end and being able to present their work here. There will be a slight program change. Bart, you will go before coffee, so if people have less coffee, it's on you. But we'll first start with Sabine on her work on liver macrophages and how we can use them to our benefit. Sabine, the floor is yours.
Okay, thank you, Christian. So indeed, today I'm going to talk about macrophages, specifically in MASH and liver fibrosis. So I will start with a short introduction into MESL-D. So MESL-D is what used to be called NAFLD, and it stands for Metabolic Dysfunction-Associated Steatotic Liver Disease. Now, it starts with increased lipid storage in the liver, leading to a steatotic liver. This happens mostly with overweight and obesity. So currently about 1 in 4 people has a fatty liver or a steatotic liver. And that number is, of course, only growing. Now, this can lead to an inflammatory response in the liver. That's when we move to the stage of MASH. This can cause them further damage into the liver, and in about 5 to 10% of all the people that have a steatotic liver, they will also develop liver fibrosis. And this liver fibrosis really sets the stage for more severe liver disease, such as cirrhosis leading to liver failure, hepatocarcinoma. But actually, the main cause of morbidity and mortality in MASH patients is cardiovascular disease. And so this was one of the largest meta-analysis that has been done on this. So they looked at fatal and non-fatal cardiovascular disease events. And they saw that just having MESL-D increases your risk for cardiovascular disease or cardiovascular events by almost 1.5. And however, when patients also have fibrosis, it increases to 2.5 times. Now, so it seems that really this stage of fibrosis accelerates disease, and not just liver disease, but also cardiovascular disease. Of course, this is very interesting, and it's also what we're interested in within our research group, but it was actually not the topic of my VENI. So all of my postdoctoral research so far has focused on the role of macrophages in MASH. So what do we know about macrophages in the liver and in MASH? Well, in a healthy liver, up to 95% of all the macrophages are the resident macrophages that we call Kupffer cells. And they have also an important homeostatic function. So what we know, what happens in MASH, is that we lose these resident Kupffer cells, so they seem to die, and we have infiltration of monocytes differentiating to monocyte-derived macrophages. And they can take on different differentiation pathways, two main differentiation pathways. So on one hand, we have what we call monocyte Kupffer cells. So these are monocyte-derived macrophages that start to look like Kupffer cells, and the idea is also that they aim to replenish this loss of the resident Kupffer cells. But on the other hand, we have macrophages that do not at all look like Kupffer cells, and we call them LAMs, or lipid-associated macrophages. And so the topic of my first postdoc, which I did when I was in St. Louis in the US, is to see what is now the role of these LAMs in MASH and fibrosis. And so one of the first experiments that we did for this is we used a CCR2 GFP mouse model, meaning that GFP is coupled to the CCR2 promoter. But actually, when these mice have 2 copies of the CCR2 GFP, they are a knockout for the endogenous CCR2. So we put these wild-type or knockout mice for 4 months on a MASH diet. So a MASH diet is high in fructose, cholesterol, and palmitate. And so CCR2 is the main pathway by which monocytes enter the tissue. So it happens that we have a severe reduction of monocytes coming into the liver. And then what we saw, if we compare the knockout to the wild-type mice, is that Kupffer cell loss, so Kupffer cell number, in the end was similar between knockout and wild-type. We saw a slight reduction in monocyte Kupffer cells, and we think that is because they still have proliferative capacity. So influx of a few monocytes, with influx of a few monocytes, they seem to be able to keep up their number. But we saw an almost complete reduction of lipid-associated macrophages. Now, what did we then see on MASH pathogenesis? So we saw no changes in steatosis. But what we saw, and this was very surprising, is we saw actually fibrosis going up. And so this was, so that means that if we have less LAMs and we have more fibrosis, that means that LAMs may actually be a protective macrophages or a macrophage or an antifibrotic macrophage. And that at that point, that really went against the general idea of monocyte-derived macrophages being pro-fibrotic and pro-inflammatory. So this is now about 5 years ago, and in the years after that, also several papers came out that confirmed this protective role of LAMs, both in MASH and fibrosis development, but also in regression of fibrosis and fibrosis resolution during MASH regression. And so this was really the basis of my VENI project, in which the general aim was to identify intervention strategies that stimulate these protective repair capacities of LAMs to treat liver fibrosis. Now, there are several outstanding questions for this, which we will answer partly in the VENI, but also in several parallel projects that are running. So first, what are actually the kinetics of LAMs during MASH and during the different stages of MASH, and are there any sex differences? Because all those preclinical animal studies have been done using male mice. Now, last year we've performed a kinetic studies in a mouse MASH model in both sexes, and I'll show a little bit of that data later on. And then we also are currently collecting liver biopsies from MASH patients, so this is part of a TKA TKI grant from Christian, but we'll also use these biopsies in the VENI project to look at lambs. Then the question is, well, what actually then makes these lambs protective? And so in the VENI, we'll be using genetic mouse models to target the lambs. And we will also now start a collaborative project with the pharmaceutical company Boehringer Ingelheim to look at lambs during regression of fibrosis. So then the next question is, well, what actually drives lamb phenotype? Because we think if we know what drives macrophages to take on the phenotype, then we might actually identify targets for intervention. And for this, so this is part of the Dutch Digestive Society grant that I received last year, as we recently did spatial transcriptomics on human patient livers, and we'll also look at the stimuli that drives lamb phenotype in cell culture models. Then for all of these projects, what is really important is that we're able to measure lambs. And for a long time, that has really been a problem in the field, as we are not able to identify lambs with conventional flow cytometry. So when I arrived at Maastricht, now about 3 years ago, they had recently, with help of CARIM, purchased the spectral flow cytometer. And what we saw there is something that we guessed we always kind of knew, but ignored because we couldn't really deal with it, and that is that the liver has a very high autofluorescence. So you can see the autofluorescence actually ranging from UV to red. And so I was able to set up a detailed autofluorescence correction strategies, and now we're actually able to positively identify lambs. Now, one of the first studies that we then applied this in is a study in which we looked at kinetics of liver macrophages during MASH development. So this was a mouse study, and we have male and female mice, which we put on a MASH or a matched control diet for either 10, 15, 20, or 25 weeks. And what we saw in both sexes is that they had limited weight gain. That's also, it's not an obesity diet, meaning that they also did not have adipose tissue inflammation. What we saw actually that females had higher liver steatosis, and they developed glucose intolerance earlier, whereas males had higher liver fibrosis and injury. So we see actually kind of the kinetics of MASH seems to be different between males and females. Then, of course, we measured all the macrophage subsets in the liver. So these are the monocyte-derived macrophages, which in the MASH groups, which are shown in red, we see that it progressively increases over time. And then when we specifically look at lambs, we see this same pattern both in males and females. And then we also wondered, well, does the percentage of lambs then change over time? So the percentage of monocyte-derived macrophages that become a lamb over compared to another macrophage subset. And there we saw that actually over time, this did not change, and it was always around 15 to 20%. So I think this just shows that perhaps we should not only look at number of lambs, but also at their function. So then, so when we talk about function, of course, the question is, well, what makes a lamb protective? And so this is an overview of a recent review showing all functions that have been described to lambs. And I think a lot of the literature out there right now focuses on their role in afrocytosis, so mostly afrocytosis of dying steatotic hepatocytes, as well as lipid clearance from the steatotic tissue. But because we saw such a specific effect on extracellular matrix remodeling, on fibrosis, we decided to look, well, do lambs actually have a role in extracellular matrix remodeling, and specifically in breakdown of collagen? So one of the first experiments that we did is we simply looked, okay, can lambs actually degrade collagen? And we showed that, yes, in vitro, by comparing them to bone marrow-derived macrophages, which we consider to be a naive macrophage. And then we also showed that in vivo in the lamb liver, in the MASH liver. And we also looked in single-cell sequencing. What do LAMPs actually express collagen-degrading enzymes? And we see, yes, they do, and it's predominantly cathepsin K and MMP14. And so in the VENI, we will now genetically target this collagen degradation capacity of LAMPs. Then next, the question is, well, what drives the LAMP phenotype? I mean, think it's mostly the microenvironment. So what is the microenvironment of LAMPs? Well, we found LAMPs specifically in structures that we call hepatic crown-like structures. So these are kind of these round clusters of macrophages that surround steatotic, dying hepatocytes. And we find these structures, and so also the LAMPs specifically in fibrotic regions. What we see is that often these crown-like structures are kind of embedded in a fibrotic matrix, and we also see that they are surrounded by activated hepatic stellate cells, which are the fibroblasts of the liver. So then what we will do in the VENI is to test candidate vectors from the microenvironment and whether they drive the LAMP phenotype. And so that will include hepatic stellate cells, it will include steatotic hepatocytes, lipids, as well as matrix components, and we'll test this in vitro primary human and mouse monocyte-derived macrophages. Then next, we are also very interested in human LAMPs because there's very little known about these cells in humans. And so what we recently did is we performed spatial transcriptomics on patient livers. So these were liver biopsies that came from a cohort of Dr. Sander Rensen of the Department of Surgery. And we included 8 patients with MASH and 8 patients with MASH and fibrosis. And so we performed the spatial transcriptomics on the 10x Genomics Xenium platform, meaning that it's not a whole genome, but it's rather semi-targeted, in that we have a pre-designed genes panel of 480 genes. Then so this is just an example of one of these biopsies. So here we can see already on the histology. So this was stained with the Xenium segmentation kit. You can already see the fibrotic regions lighting up in this liver. Then, based on this staining, the program will then perform segmentation of our individual cells and perform clustering based on their gene expression profile. So in this case, each colored dot is a single cell, and when the cells have a similar color, meaning that they have a similar gene expression profile. Then we also, in our panel, we had genes that were related to liver zonation as well as fibrosis. So here we can also see that we'll be able to perform analysis based on the area of the liver. And so then, of course, one of the first very important questions that we had is, can we find LAMPs in these livers? And in this specific liver, we actually found 2 clusters of cells. So in this case, they were green and, they were shown as green and orange, and they had a LAMP-like phenotype. And also, as we expected, we find them specifically in the fibrotic regions. And so this was for us just a first glance at the data. So there's a lot of things that we have to do now. So for example, we have to perform clustering analysis across all the biopsies to look at the macrophage subsets, and then also identify, we're also interested in what are the neighboring cells of the LAMPs and what is their expression profile. Then, just to summarize, what is kind of the end goal, I would say, of my research, and that would be that we could design macrophage-targeted therapies that utilize kind of their natural repair capacities to halt but also reverse liver fibrosis. And I think right now, with all of our projects, we're taking kind of a broad approach to this. So we go from cells to mice to humans and also back. And maybe if I can then dream a little bit more, we actually also found LAMPs We find LAMPs in other tissues, especially in metabolic disease. So the question is, to what extent is the knowledge that we derive from these projects also applicable in other fibrotic diseases, in metabolic disease, or even beyond? So of course I do not do this alone, so these are really the most important people that helped with this research, and of course our funders.
Okay, thank you, Sabine. There's time for some questions. Whoa, way at the back. Okay, people, you need to help me now. It's over there.
Okay, thank you for the very interesting talk. You've talked about phagocytosis and the formation of these LAMPs, but in your disease models, do you also see effects on efflux? Because I also suppose that whenever there's disruption in efflux, the LAMPs become an inflammatory phenotype.
Sorry, I mean efflux of?
Of lipids, for example, by ABCA1, ABCG1, because then your anti-inflammatory state kind of becomes an inflammatory state. So do you see these things happening in the disease models that you're studying?
Yeah, so I know kind of these inflammatory LAMPs have always been described, for example, in atherosclerosis. Actually, we do not see them in the liver. Why that is, we don't know. It doesn't pop up at all in any of the single-cell sequencing or whatever. So it seems yeah, they do have a lot of receptors for lipid uptake, for example, but it doesn't seem that they really get an inflammatory profile from it.
Okay, thank you.
There's time for one small. I will throw this at you.
Thanks for that. Great presentation, and nice to see your goals, your long-term goals, and what you've already achieved. Very, very good. So when you are studying the spatial is very interesting, but there's already a lot of single-cell data of the livers out there. Have you already done some niche net cell chat to see if there's any other receptor ligand pairs that can show you that you can already start working on for the cell communication angle?
Yeah, that's really important. That's really interesting question. We haven't done it ourselves, but there is a group at the VAB in Ghent that does this work a lot. They actually have, but they have mostly done it in healthy livers, and that's also because there's barely any, there's very little data out there in human livers. So I think, yeah, at this point we haven't done it ourselves also, but I think it would be really interesting to do, yes.
Okay, then we'll have to move on with the program. Thanks, Sabine. Bart, you will move up a little bit in the schedule. So we move directly from the veni to the vidi. On Bart, who will look at vascular stiffness in the aorta and see whether it holds some clues to why people do or do not respond to antihypertensive treatment. So Bart, the floor is yours. Thank you.
Well, first of all, thank you very much for the invitation to give this talk. I'm really honored to be standing here. So I'll be presenting my recently awarded VD grant, which is about the aorta as a role to, as a key to personalized hypertension treatment. So let me see how I move this forward. So 1 in 3, that's the number of people with hypertension worldwide. And hypertension worldwide leads to approximately 11 million deaths per year. So what do we do with someone who has hypertension? Well, we actually treat them with antihypertensive drugs. But despite these treatments, these people still have uncontrolled hypertension, or I have trouble with my mouse a little bit, because it's okay. So but many people still have uncontrolled hypertension, or they have overtreatment or side effects. So what's going on here? So I think we're missing something, namely the effect of these drugs on the aorta. So here you see such an aorta, and with each heartbeat, the aorta dilates and buffers the blood that is ejected by the heart. However, this aorta also contains smooth muscle cells, and these cells can contract, causing vasoconstriction, but can also dilate, causing vasodilatation. And likely, these antihypertensive drugs have a direct effect on this active behavior. However, up until now, we don't have the methods or tools to assess that effect. Therefore, in this Activate project, I will develop patient-specific computer models that are able to take into account this direct effect of these drugs on the aorta, with the end goal to better personalize hypertension treatment. Now, before moving on, you may be wondering, hang on, the human aorta, can that actually contract? Or are these smooth muscle cells simply there to produce matrix? Well, in short, yes, it can contract. We performed a large review and found several studies that showing that the aorta responds both to dilatory and contractile stimuli. And I think it's best exemplified by this study by Gebner et al., who looked at the acute effect of nitroglycerin, so a short-acting vasodilator, on the aortic buffering function. So what do we see here? We see that if you give people nitroglycerin and wait for 4 minutes, that first of all you see a very big spread in results, so that in some people the Bindkessel function or the buffering capacity increases by 50%, but in other people it decreases by up to 70%. So what's going on here? Well, let's first move back to the antihypertensive drugs. So all antihypertensive drugs basically reduce mean blood pressure. So if you look at this blood pressure fluctuation on the right here, you see that they simply move down this curve. However, some of the drugs actually work through vasodilatation, and likely these drugs also vasodilate the aorta. And the key question now is, does that increase or decrease the buffering capacity of the aorta? So why am I saying that? Well, the aorta contains smooth muscle cells, of course, but also matrix, collagen and elastin. And so when you vasodilate the aorta, the pressure load will shift from these smooth muscle cells to the matrix. And now the question is, if this matrix is flexible, this leads to a more flexible aorta and to more buffering capacity, so the blood pressure fluctuation will diminish, so the pulse pressure will decrease. Conversely, if your load shifts to a stiff matrix, think of an elderly person, you're offloading to a stiffer component and you have less buffering capacity and your blood pressure fluctuation increases. And as you can see here, that actually increases systolic blood pressure. And obviously, when treating hypertension, that's not what you want to be doing. So the key question here is, okay, how does this work for an individual patient? And not just in the short term, acutely, but also in the long term. So to study this, I will first look at small aortic tissue samples. And what I'll do is I'll cut them out of the aorta and put them in what we call a planar biaxial tester that we also bought thanks to CARIM. And we'll subject them to either vasoconstrictive or vasodilatory stimuli. I'll first do this using pig samples to get this method up and running and to see how this mechanical behavior generally looks, and then switch to samples from human organ donations. And there also look at, okay, this contractile effect or this dilatory effect, how does that relate, for example, to age, but also to people with chronic kidney disease, so to confounders. So you may be wondering, okay, can we do this? Yeah, we tried to look at aneurysm tissues from the OR of Alan Bidar, and you see indeed that aortic tissue can significantly generate force, and also interestingly, not just in the circumferential direction, but also in the length, in the axial direction, which is really important also to take into account in my personalized modeling. So once I have this proper characterization of aortic contractile behavior, I will use that to improve a computer model of the blood circulation, CircAdapt. And I'll expand that model with a contractile aorta. So how will I do that? Well, first I will measure the aorta and basically create a virtual aorta, so a computer model of just the aorta in isolation. And I will do that in progressively more complex ways. So I'll start with a very descriptive way, just describing the relationship between pressure and diameter, and then move on with a constitutive way, so taking into account collagen, elastin, and smooth muscle cells. And finally, also take into account how these components remodel over time. So we have growth and remodeling in there. So once I then have this complete description of the human aorta, I'll take that virtual aorta and put it in our circulation model. And finally run what we call a sensitivity analysis. So basically we look at, okay, if we change model parameters, how does that affect the model behavior? And okay, how does this look then? So if we look at the CircAdapt model and indeed just change the aortic behavior, the aortic compliance, the thoracic aortic compliance, you see already that you have a significant effect on pressure, meaning that indeed CircAdapt is a good platform, feasible platform to do this. So once we have this, what we can do is we can personalize this computer model, this circulation model, to an individual. And basically what we have then is a digital twin of someone's blood circulation. And what I will do then is I'll use this digital twin to simulate the effects of different antihypertensive drugs in order to also check and refine this model. And I'll do this based on published data. So I'll start with very acute effects of nitroglycerine. So here we don't assume any growth from remodeling because the time frame is way too short for that. And also look at effects of 1 to 3 days of common antihypertensive drugs. So once that works, I'll move to longer term studies, so the effects between 1 and 6 months of antihypertensives. And finally, I will use the SPARTA study. So the SPARTA study has half-yearly follow-up in a lot of patients with different hypertensive drugs. And so I can look at, okay, how does remodeling progress for 4 years in these patients? So after that, I have my platform done, basically, and what I'll do is I'll run a validation study in patients. So the aim really is here to validate the model prediction of hypertension progression. So what will I do? So I'll look at patients coming to the hypertension clinic at our hospital, and I'll randomize them into 1 of 2 arms. In one arm, they get additionally a calcium channel blocker, and in the other arm, their diuretic dose is increased, or they get a new diuretic. And the idea of this is that likely a calcium channel blocker has a vasodilatory effect and a diuretic does not. So I expect in arm 1 there to be vasodilation and in the other arm not. So I'll look at patients at baseline here, where I'll perform a measurement in rest, but also 4 minutes after a nitroglycerine stimulus. And then I'll repeat after 5 days, after 84, and after 168 days. So what will I actually measure? Well, I'll measure a lot of things to basically also check whether my digital twin corresponds to hemodynamics realistically. But the most important thing is I'll measure the ascending aorta diameter using transthoracic echo. And so we did this in 3 volunteers. One of them is myself, and indeed you see in baseline the solid lines and in dashed lines the dilatory effect. So you indeed see this dilatation, so a shift to the right, but you also see already that the slope of this curve, which is basically the stiffness of the vessel, that effect is very different between people, which is indeed what I was expecting. So how is this then going to look in terms of patient recommendations? So what I tried is to very preliminarily run a digital twin simulation based on data from our collaborator in America, and looked at 2 patients that are very similar in terms of blood pressure actually, and heart rate and other patient characteristics. However, when they were subjected to nitroglycerine there, in patient 1 this increased the stensibility, so buffering function of the aorta, and in patient 2 it decreased. So if we then simulate their blood pressure fluctuation in our model, this is the baseline simulation. If I now in silico treat this patient number 1 with a calcium channel blocker, it's obviously going to decrease mean pressure. But if I compare that to a diuretic, in this case, the calcium channel blocker does a better job also in decreasing the systolic blood pressure. However, if we compare this to patient number 2, you see a very different thing. So you see a baseline curve, and there you see actually calcium channel blocker, despite decreasing the mean pressure, increasing systolic pressure so much that the net effect is a pressure increase systolically. So as you can tell here, in patient 1, you would recommend a calcium channel blocker, and in patient 2, you would recommend a diuretic, for example. So this concludes my methodology. So what do I need to actually get to this methodology? Well, I'll need a combination of skills in computer modeling, in mechanics, and also in clinical experimental studies. Well, I attained some of these skills during my PhD here in Maastricht, but also during my 2 international postdocs at Macquarie University in Sydney and at Yale. But obviously, I'm an engineer. I cannot do this myself. I need collaborations, so collaborations with clinicians, with experimentalists, and also with engineers. So how is this going to look? How do you envision this to look in clinical practice? So currently in Maastricht, this is what we measure in a newly diagnosed hypertension patient. So what I will do is I will add 2 small measurements, namely a measurement of aortic diameter added to the already performed echo core, so the cardiac echo, and I'll continuously measure blood pressure at the fingertip. And I'll do these at baseline, but also after 4 minutes after a nitroglycerine stimulus. And then these data are fed into my model, so that's made patient-specific, and the model basically will inform the doctor, okay, is for this individual patient vasodilatation beneficial or harmful? And then based on that, the clinician has an additional tool to choose between different antihypertensive drugs. So I also talked about this with the Heart, so a patient organization sent my proposal, they gave feedback on it, and then I incorporated that feedback. And being on the latest ESH guidelines, I also hope that this will help me to implement this eventually in clinical practice. So I think it's high time that we actually take into account these individual effects of separate drugs on the aorta. So this video grant for the patient will lead to a more personalized medication choice, to less side effects because there's lower medication burden, and also to a better understanding of their disease and therefore better adherence to their medication. And for myself, it will lead to a scientific breakthrough, the first digital twin platform for the personalization of hypertension treatment, an increase in translational expertise, and a strengthening of my research leadership and biomechanics. So I'm very much excited to take on this challenging project. So I want to thank you for your attention, but not before I thank many others. First of all, NWO and Zonneway for giving me the opportunity finally to run this exciting project. Of course, all the collaborators involved here for their input on the grant, but also for willing to work with me on this project. Of course, my team at the Department of Biomedical Engineering, who were all involved in collecting the pilot data, performing the pilot simulations, and in general, helping me develop this idea. To Tomo for all of your hard work in tirelessly reviewing and improving the textual parts of the grant. To my colleagues, Suze and other colleagues at the department for your support. The CARIM Research Council, with whom I've repeated this and practiced this grant multiple times and also received feedback. The grants office and Van af Nul. So Van af Nul are two trainers in presentation skills. But finally, also my family, my wife Eileen, my son Seth, and my daughter Fien. So this is Fien. She was 2 weeks old when I defended this VD for the committee, and I think that mindset actually made me get the grant, that calmness of that situation. And with that, I want to thank you for your attention.
Thanks a lot, Bart, for a really nice presentation and really, yeah, persistence is everything, right?
Thank you.
Well done. Questions from the audience? Fritz, I'll start with you. The other one can gently, but don't throw them at the back of people's heads, right?
Okay. But congratulations, first of all, for the VD grant, well deserved.
Yeah.
And it's great that this very basic physiological property of the aorta, which we all tend to forget in this term, that you pay attention to that. So you study drugs that have more or less direct effect on the aorta, but another kind of drug that is used is beta blockers to treat hypertension that may not change properties in aorta, but does change heart rate and therefore stroke volume.
Yeah.
So how do you, and while on the other side, vasodilators may increase heart rate because they lower the mean blood pressure. So how do you rank the effect of heart rate in this whole system?
Yeah, so good question. So this is exactly why we need a digital twin, because at some point, so I can try to reason through this effect and I'll maybe get somewhere, but this is exactly why we need heart rate. And you may have noticed that these two pilot patients that I did, they had a different heart rate already. And you see, of course, that also that indeed has effects on stroke volume. So the higher the heart rate, typically the lower the stroke volume and vice versa. So I find it hard to give a direct answer. This is exactly why we need this methodology, basically. So I look forward to looking at this. And as you probably know, one beta blocker is not the other. There's also different classes there. So also there expect different classes to be more vasodilatory and hence have bigger effects here than others.
Thank you. Yeah, I congratulations again for your grant. It's great.
Thank you.
And I also very much enjoyed the talk. There was something that I had as a question that was floating around in the background is what makes the aorta respond in one patient in one direction and what in the other? What biologic property is causing that behavior, and does your grant also answer that question?
Well, so I think a key thing is, so basically you can look at the aortic mechanics as a summation of the smooth muscle cells and the matrix. And as soon as you vasodilate, you have less, the smooth muscle cell contributes less. So the load simply shifts to the matrix. We've also seen this in mouse vessels. And so the key thing is this matrix, basically, is that if that matrix is super stiff, this pressure diameter curve is very steep. So for example, there's no elastin anymore because the patient is old. Then offloading to that is going to be bad. It's going to cause buffering function or Windkessel function to drop. And vice versa, in a young athlete, if you dilate to a very flexible aorta, it's going to be better. So that's my. Of course, it's more complicated than this. There's more than just elastin breakdown. There's also collagen remodeling likely, and also wall thickening. But that's the general principle. And the nice thing is, of course, there's going to be hundreds of pathways and mechanisms involved. But it all boils down to understanding. Okay, how does it behave? So how does the pressure diameter curve look like, basically, in a contracted state and in a passive or less contracted state, at least. And by knowing that, you can simulate vasodilation and its effect on mechanics, and without going into all the details that are for sure there, have an idea about, okay, this is a good or bad idea for the patient, basically. I hope that answers your question.
Thanks, man. The last, hopefully not too long question from Uli.
Short question. Fantastic, Bart. I'm very, very happy to see that in the end it worked out positively. Congratulations. I wonder whether you have the opportunity also to look at long-term effects. So right now, in the plans you just presented, you look at the short-term effect. But of course, there are a lot of very interesting things going on in the long term, such as the effect of long-term stretch, such as different angiotensin II levels. They are very different depending on the drug that is chosen, even within one class, ARABs versus ACE inhibitor, and with different subclasses of angiotensin II receptors. This may have protective effect versus detrimental effects. So is there an opportunity in your study to look at the long-term change of the parameters you measure as well?
Obviously. So the Sparta study that I was referring to, that is 4 years follow-up. So that I will of course see whether my model can describe that. I chose to not run my own patient study for that long of a time simply because of time restrictions of the VD, basically. But my plan is for sure that once the VD is over, or towards the end of the VD, to actually run a study where I randomize people not between two drugs, but rather between conventional treatment and digital twin informed treatment, and then also look at a longer follow-up of, the longer the better, of course, but this is also going to be limited by practical means. But you're absolutely right. We should. So this is only the start.
Great.
Good. Thank you, Bart. So that brings us to the coffee break. Not just like that. First, before you can get coffee, we would like to ask you to convene in the hall where the Christmas tree is standing, where Sandrine will take a really nice picture of everybody so that Tillman can do a head count via ChatGPT, right? That was the intention. So, and then afterwards we'll just convene to program in 10:40.
Okay.
Thank you.
Thank you.
Okay. Welcome back, everybody. We'll have to start because we're already running 5 minutes late now. So, for our next speaker, I'm happy to present Uyen Gwen, who will present her VINI proposal. You weren't there yet, but you already popped up on the pictures in the introduction by Tilman, so it was quite the year for you. So Uyen will talk about our VINI project on myocardial scarring and the implications for treatment. So, floor is yours.
So let's see how it works. Okay, so good morning everyone. Thank you for the opportunity to present my VINI project for you today. I would like to take this opportunity not to present too much work about myself, but also to shine spotlights on my students, because others than I was here 3 years ago and I focused more on my own work, but now my work has really changed and I'm more like a supervisor or a mentor to my students than doing the research alone. And it's also important for me to stretch that this VINI project is actually an integrated part of a few other complementary projects, which I'll also briefly present to you. Ooh, how does this work? I'm a cardiologist in training and then a clinical technologist, but my daily work is, in daily life I work as a clinician. So heart failure, as most of you already know, is a disabling disease with a high mortality and high morbidity rate. And in about 1 out of 4 patients with heart failure, they do have an underlying electrical conduction disease, which is also known as dyssynchrony. And in the majority of patients with heart failure also have myocardial scar due to coronary artery disease. And these patients are more prone to a poor prognosis. Patients with dysynchronous heart failure can be treated with a guideline-recommended treatment, which is cardiac resynchronization therapy, which is a pacemaker therapy that electrically resynchronizes the ventricles continuously. And conventionally, this is done by biventricular pacing, where a lead is placed in the right ventricle from the inside and on the outside through the coronary sinus tributary on the left ventricular free wall. But lately, we now also have left ventricular septum pacing, where a pacemaker lead is placed screwed through the interventricular septum, stimulating the septum with or without capturing the conduction system on the left side of the heart. Despite the proven effect of cardiac resynchronization therapy, about 1 out of 3 patients still derive suboptimal benefit of this therapy. And my research for the past decade almost already has been focused on getting better mechanistic insights why these patients respond poorly to cardiac resynchronization therapy, and also by striving to really improve patient care by improving the delivery of the therapy and by implementing novel technologies, because I'm also a clinical technologist, so I like technologies. My Zonnebeheer VINI project has been divided in 3 main projects. In the first project is focused on characterizing the electrophysiological impact of scar in high resolution. And the motivation behind this is the work from one of our medical student, master student. He became a physician now already, he graduated just very recently. But in this work, and also in my previous work as a PhD student, he has shown that in patients who have an underlying conduction disease, it is very hard to detect myocardial scar from the standard ECG. So here you can see an ECG in a patient with a conduction disease without scar, and this is the ECG simulated in a model with scar. So you don't have to be a cardiologist to see that these morphologies, they look very much alike. So the ECG is not very useful in looking at scar in our type of patients. So that's why my motivation was to look into more high resolution. Can we see how do these signals look like in the presence of scar directly on the epicardium? And for this, we use a cohort that I've been collecting during my PhD my PhD trajectory, and also during my first Dekker project, where Karin, our PhD student, has expanded this ECG imaging cohort, where we conducted ECG measurements with 200 electrodes, and were able to reconstruct the potentials directly on the epicardium. And what we do is we fuse it with myocardial scar from MRI. So we also collaborate with radiologists and imaging cardiologists. And we will want to look at every potential in myocardial scar, how it differs from outside scar. So if we have this information, we might use this information to generate a computer model where we can simulate different pacing strategies within the models. And these models will be generated based on data from the first work package. And I will give you a little bit more explanation about that, because this model is based on an existing electromechanical simulation platform developed by Roel and by Joost in CARIM together with the TU Eindhoven. And in a granted project in the Dekker Team Science that was also granted this year, we will further develop this generic electromechanical simulation platform to make it available to do patient-specific measurements, and also to we want to develop it one step further ahead to so that the model can also generate ECG, so we can get more understanding from the model on what we see on the ECG. And for this input to improve the model, we will use existing data, of course, to start with, but we will also collect new data in a clinical study that will be led by Julien, who is a new PhD student from France, and where we will include about 30 patients who will be scheduled for CRT. And during implantation, we will perform different resynchronization strategies and measure invasive blood pressure, electrical activity during different pacing strategies, but also the mechanics using echocardiography. And all these very dense information will be used in our computer model. Officially we are only starting the VINI next year, but of course this idea was already 1 year old, so we could not wait to start, so we actually already started with the first simulation. So this is the first, this is the work from Stijn, he's also here. He is a biomedical engineering master's thesis student, and he used the data from my ECG imaging cohort. So this was a patient with myocardial scar, so blackest scar, and he was already able to simulate ECGs in a computer model. So that was already very, very interesting for me as a clinician. But he also showed in this model that this patient would benefit most when you pace the patient in a septum combined with pacing electrode on the left ventricular free wall, which is LOT CRT. So you can see that the heart here is more red, so which is more synchronous than the other strategies. So in the third project of the VENI project, because I'm a clinician, I also want to really improve the clinical pathways for the patients. So we want to use all the mechanistic insights from the computer models, from the ECG imaging studies, to develop a more standardized protocol for pacemaker, for a follow-up of patients who received left ventricular septal pacemaker, and also on how to program these devices, especially when you combine the left ventricular septum electrode with the left ventricular free wall electrode. We don't often do that. That's something we only recently start doing it. So that is the goal of the third project, and a little bit motivation behind that. So this is the work from Johan, who is a PhD student from Kevin actually, but sometimes he comes to me as well. And where we as clinicians, we use the ECG as it's a cornerstone of our clinical practice, and we sometimes think we can really read from the ECG if the conduction system is captured or not. So what we tested last year, so we showed paced ECGs to worldwide experts in conduction system pacing. It was not me, these were experts. And we asked them whether they would think if the conduction system was captured or not. And surprisingly, even within these experts, the inter-observer agreement, but also the inter-observer agreement was quite low. It's a bit disappointing. So this means that if I would show 10 ECGs to 2 different experts in this field, they would disagree in half of them whether the conduction system was captured or not. So this gave me a little bit motivation, like how can we help us clinicians? We need something more. So the ECG is prone to clinical judgment. I want to make it more objective and also more efficient. So I asked Sylvia, who's also here, our master thesis student, to develop a program to semi-automatically quantify the ECG, because I want to have it semi-automatic, because I'm a bit neurotic. I want to see what's happened with sickness. I just don't want a black box AI model. I don't like that. I really want to see if the program is doing what I can physiologically explain. So she made this semi-automatic algorithm, and she also let me and two other clinicians judge 50 ECGs, and she found that there was a quite high inter- and inter-observer correlation with conduction system capture parameters when using this algorithm. So very promising. She's also going to present this at the ERA Congress. So yeah, I already told you, like, we are developing tools to semi-automatically quantify the ECG, but I would like to take it one step further. So of course I like computer modeling, I like ECG imaging, because it can provide us a lot of mechanistic insights, but we have to be honest, it's not really applicable for standard clinical care, because to generate a computer model or patient-specific computer model of the heart or a digital twin, it takes actually several days to do that. So that's why I've also been looking into other technologies that are a bit more advanced than the ECG, but still have the simplicity of the ECG. So, and one of the most promising methods in that field is the ultra-high frequency ECG, which is a technique that is for the patient. It feels exactly the same as ECG. So the patient just gets, instead of 8 precordial electrodes, but it measures the ECG with a higher frequency ranges, and it uses very smart technology to visualize the ECG in two-dimensional real time while we are measuring the ECG. But it also provides the conventional ECG, because, yeah, as clinicians you can never replace the ECG. And what I want to show you, so this is a patient who was referred for cardiac resynchronization therapy, and you don't have to be, I think, a cardiologist to see that this looks much better than that. So this is during intrinsic activation, and this is during cardiac resynchronization therapy. So in this patient also left ventricular septum electrode combined with the left ventricular free wall. So to further implement this technology and investigate the usefulness of this technology in pacing therapy, but also for the prevention of arrhythmias, we've been also granted a public-private partnership consortium grant and a stipend grant last year. And we've been able to appoint Florien Klein, who is a cardiologist in training from Catharina Hospital, to conduct this project. And what she has already shown, she's only started a few months ago, is that when you use ultra-high frequency ECG instead of the standard ECG, you can see that in women who have a similar QRS duration on the standard ECG, they actually exhibit more interventricular dysynchrony that you cannot see on the ECG. And this is very interesting, because we know that women are very much undertreated in cardiac resynchronization therapy, but somehow respond much better. So this also can provide us more mechanistic insight from why women respond better, and maybe it can help us in better selecting women or have other selection criteria for women to offer this therapy. So with this, I would like to thank you. So I've already shined spotlights on almost all, but not all of my students. But I also want to give some spotlights to my supervisors, of course, Frits and Kevin, one preclinical supervisor and one clinical supervisor, because they have been inspired. Yeah, they've inspired my work for almost a decade already. And I want to thank you also for the attention.
Thank you, Jan, for a really great presentation. Are there questions? Maybe I'll kick off. I was a little bit interested in your neurotic feature. So I fully agree. Let's start there. That you don't want to, especially in patient things, let AI just decide. Mm-hmm. But what is then still the human touch that you need? Were you able to identify where still this human touch is needed? And do you think, Obviously, that's your experience as a doctor, but do you think that AI at a certain moment will be able to
Yeah, I like AI. I think in one part it is just an advanced statistical model, so that can help us in identify, it's more advanced statistics to identify certain parameters to find correlation, and I like the use of AI to make our models more efficient so they can be more prepared for real clinical use. But I don't like the black box AI that tells me as a clinician what to do if I cannot really understand it, or I have to be able to understand it so I can also explain it to my patients why I think it's best for them.
Yeah, but you did not. Yeah, obviously you did. You only made the semi-automated model. You did not compare to a fully automated, right?
Yeah, no, I don't do fully automatic because then, you.
Clear. Yes. In the meantime, any other burning questions? If not, then thank you, Jan, and for a really nice presentation, and good luck with the research.
Thank you.
And then for the final presenter of this session is Judith Sluimer. She was awarded the Vici Grant. Ah, there you are. I was looking for you. So, Judith, I mean, all the other candidates will testify that it's really, really hard to get a Veni or a VD, and a Vici must be even harder. But maybe it's you beat all the odds by getting all three, right? And if I remember correctly, also the Rubicon. So yeah, that's 4 out of 4. So that's really impressive. So congratulations on that. So yeah, the floor is yours to tell us on how we can rejuvenate at least our vessels.
Well, thanks for that introduction. Maybe I should start off by saying that all of the work that's presented here seems excellent, and they all seem like straightforward research output. But we all know, of course, that it's never that simple, and that things are not always so simple as at first sight. Also becomes obvious maybe when you take a look at this skyline, where you can potentially recognize already the bridge of Maastricht. But if you look a bit closer, this is actually the skyline of 3 cities that I'm affiliated to. So things are never as simple as they are, and this as they look in science. And this is also true when studying the cells of the vasculature. So we all learned in Biology 101, endothelial cells line the lumen, and medial cells inhabit, the smooth muscle cells inhabit the media. But there's a lot of cells in the adventitia that are often overlooked. And one of those cell types are the fibroblasts. And fibroblasts are connective tissue cells that are present in all organs, and they are mainly known to drive fibrosis. While that is detrimental in many of those diseases, actually fibrosis is beneficial in the pathogenesis of atherosclerosis, because there we're trying to prevent plaque rupture, and a thicker, stable cap with more collagen is actually considered good. And now when this work started, there was actually no evidence yet of fibroblasts in atherosclerosis. This was the time before there was even single cell sequencing. So I'm missing a few slides here. Well, anyway, I'll start by saying what was on the slide that was missing. You see, things are never as you want them to be. But what I was doing when I was studying the Veni is that we were studying the role of hypoxia in atherosclerosis, and we had a massive increase of fibrosis in these plaques. So instead of first looking at fibroblasts, because they weren't even considered at that point, we studied the function of macrophages and smooth muscle cells. But obviously we couldn't actually explain the function in fibrosis at that point, not until we included also fibroblasts in this game. And when we then showed that fibroblasts were actually, at least in vitro, responsible for this massive increase in fibrosis, that was actually the start of my interest in fibroblasts, and if they could potentially be a new target in atherosclerosis. So for the last long period of time, we have been studying with some past team members here, marked in gray, and the other current team members in a color picture have been studying whether this actually could be true. So we wanted to establish fibroblast function, but before you can do this, you actually need to know what fibroblasts exactly are. And Kim, the PhD student at the time, quickly ran into problems there because the markers that people were using in the field to distinguish fibroblasts from smooth muscle cells were actually completely inadequate. So we first needed to establish their identity, and we also needed to know where they were coming from and whether they were actually staying fibroblasts or whether they were transitioning into another cell type. And this is particularly, of course, relevant if you want to target a cell, and if it's changing, you need to change your target. So for the VD at that time, we used the standard, or these days, a standard study approach with 10x genomic sequencing, where we started out with healthy adventitia, and we enriched for we enriched for mesenchymal cells, so we got rid of all the endothelial cells, all of the macrophages, and we then looked to see whether we could find differentially expressed genes between smooth muscle cells and fibroblasts, and after validations, we were hoping to get some targets that we could use to knock out and study their function, or to trace with the lineage tracing model and see where they were coming from and how they were ending up. And we were able to do that, and we found two markers, platelet-derived growth factor receptor alpha and dipeptidase 1, that marked adventitial fibroblast. And on the left here, you can see violin plots, where the blue violin indicates that there was expression on mRNA levels of these two markers in fibroblasts, but not in smooth muscle cells. And after that, we confirmed our data in several other data sets, and that held up. What we also did is looked at these markers on protein level, because you are digesting tissue, you don't know whether that will change the mRNA expression, so you really need to validate those findings. And what you can see here is that in the four images is that here the fibroblast markers are labeled in red, and they're not co-localizing with smooth muscle cell markers SM22 alpha in green, or CD31 and endothelial cell marker also in green. So with this study, we were able to resolve the identity of fibroblasts in healthy arteries. But what about fibroblast identity in plaques? And was it also that simple? Was it one big happy family, or were they quite heterogeneous? Now that question we answered by combining about 30 data sets of mouse atherosclerosis, and thankfully I have two very good bioinformaticians in my group, and Guanliang Li was able to combine all this data, integrate it, make sure there was no batch effect, and he could find that there was 4 subsets of plaque fibroblasts available. And when we did gene ontology analysis, you can then assign their names and their putative functions to these subsets. Now, all very well that we can do this for mice, but we are not in the game to treat mice, we are in the game to treat humans. So what about subsets in humans? So he was able to also integrate this across species. So we used 2 or 3 data sets from human atherosclerosis and control arteries that were out there and integrate them. Now, this is also not a small feat because the simple technology that's out there for integration was not sufficient, and he had to use a Saturn, which is a sophisticated model, also including protein large language model, to actually integrate this. And I'll try and guide you along this. So what you see on the left are the mouse fibroblast subsets, and if you focus on the light yellow one, you can see that it's also overlapping partially with the dark orange one on the far right corner. And the same is true for the light and the dark red subsets, the light and the dark blue subsets, and the light and the dark green subsets. So we had 4 million plaque fibroblast subsets that were also conserved in human, which allows us to study, of course, their function also in animal models. What you can also appreciate is on the right side that the human fibroblast subsets are many more. So the situation in human is far more complex than in mice. And we believe this is due because patients obviously also present with a lot of comorbidities, and mice are just hypercholesterolemic. So what about the origin of fibroblasts? Our attention was actually quite quickly drawn to that yellow fibroblast subset that was also marked by a gene called CD55, because that we already saw in our healthy adventitial fibroblast data set. And we also know that this subset is expressing progenitor markers such as Ly6A, which is also known as SCA1, and CD34, suggesting this could be the progenitor fibroblast subset. Now, with some more computational models, we were able to confirm that indeed the yellow subset was the most progenitor-like. And with further modeling, Guanliang could show that indeed, the progenitor fibroblast was predicted to be the origin of the other 3 subsets, and you can see that by the vectors pointing towards from the yellow towards the other subsets. So that suggested that CD55 positive fibroblasts that we already detected in the healthy adventitia could be the origin of plaque fibroblast. Now, to get some more experimental model supporting these predictions of the RNA data, we used a lineage tracing model. So there we made use of this marker, PDGFRA, where a lineage tracer model existed. So what we did was, after tamoxifen treatment, all the cells that were expressing PDGFRA at that time would start to express a fluorescent protein, TD tomato. And not only that, if the cells split, they also pass on that fluorescence to their daughter cells. So you can always trace their fate and see where they're coming from. In addition, we gave these mice and we make them overexpress PCSK9 to delete the low-density lipoprotein receptor. And in combination with a high cholesterol diet, mice then develop atherosclerosis. So what you can see on the images here is that indeed the TD tomato labeled cells are lining the adventitia, are lining the media. They're in the adventitia. And when you are, I still seem to have a problem getting the pointer going.
It's going on the big screen.
But I need to. Oh yeah, I see. But I want to. Yeah, you can't see it here. Anyway, but now I can see it over there. So anyway, if this is a plaque, this would be the media, the lumen would have been here. This is the aortic root region we're looking at, and you can see definitely there's plenty of red cells there ending up in the plaque. And this increases with increasing diet duration. So with this project, we then established fibroblast identity and their origin, and with sophisticated analysis further on, we also showed that the majority of the fibroblasts actually maintain their identity, and only a few of them, maybe 5 to 10%, start to differentiate into muscle cell-like cells in the plaque. What we didn't really show yet was function. And here we actually turned our attention to the other marker we discovered, dipeptidase 1, because it didn't have any known function in the vasculature, which intrigued us quite a bit. So DPEP1 is located on the membrane, and it hydrolyzes dipeptides. And what is quite interesting is that it's also involved in the synthesis of an antioxidant, glutathione, and this is quite important for the rest of the story. This still didn't tell us much what it was doing in the vasculature, so we also looked in those catalogs of genome-wide association studies. And we saw that DNA variants in human DPEP1 were actually associated with blood pressure. Now, to get a better handle on the directionality of this association, we then turned to a colleague in Poland who has quite a lot of experience in Mendelian randomization. So what he did was he looked at the correlation of the association, the predictive value of SNPs in DPEP1 for plasma levels of DPEP1. And he found in 2 different cohorts, 2 SNPs that actually predicted quite strongly the level of plasma DPEP1. And then he could use that actually to predict the association of plasma DPEP1 to blood pressure in the UK Biobank and the International Consortium for Blood Pressure, which was a negative association. So human plasma DPEP1 correlated with low blood pressure. Now, Mendelian randomization is, of course, already a stronger tool that suggests causality, but to hammer this actually even further down, we also got our hands on the DPEP1 knockout mouse model. And here we first looked at the young animals, and we didn't see any changes in blood pressure. But since we collaborated with a group during COVID with a group in Canada, and we couldn't actually go there to analyze the mice, and the mice couldn't actually come to us to be analyzed either, they started aging. And in the end, the aged mice actually did show a small increase in blood pressure. And now this doesn't seem like a lot, but for mice without any other trigger than just physiological aging, to have an increase in blood pressure was quite significant. But to make sure that this was still not an artifact, we also subjected these mice to a second model of hypertension, which is the angiotensin II mediated increase in blood pressure. And here you can see that indeed, both in red, the knockouts were always showing higher blood pressure than the wild types in black. So we figured that, fibroblasts, fibrosis would increase stiffness, the simple explanation. But again, the simple explanation was actually not true because we didn't see a change in collagen, and we certainly did not see a change in pulse wave velocity as a measure of vascular stiffness. So stiffness couldn't really explain those effects. What we then did in the collaboration with a lot of scientists here in CARIM was to study myography. So you can study the contraction and relaxation of isolated artery segments. And what we found there was that both contraction and relaxation were compromised in the knockout mice, again in red. Since we really confirmed by all sorts of double stainings that DPAP1 was not expressed in smooth muscle cells and in endothelial cells, we did think it must be in some sort of paracrine action, but mediated by smooth muscle cells or endothelial cells. So with some extra experiments, you can then rule out study the contribution of endothelial cells and smooth muscle cells. So in the graph on the right, you can see that if you bypass the NO production by the endothelial cells by giving this, exposing the arteries to nitroprusside, that we weren't able to restore the effect, suggesting that this effect was endothelial cell independent, and that it would be something mediated by smooth muscle cells. So we then turned our eye to the smooth muscle cells, and when we stained all the arteries we collected for contractile gene markers for the smooth muscle cells, we saw that the amount of smooth muscle cells did not change. Also, the thickness of the arteries didn't change. But we did see a reduction in the contractile gene expression proteins such as myosin heavy chain 11 and SM22 alpha. And this is known in the field that smooth muscle cells undergo a phenotypic switch away from their contractile normal appearance. Now, in the further experiments, we showed that this was due to increased oxidative stress in the knockouts, and that we could actually rescue this phenotype in vitro by giving the mice glutathione. So that would be the contribution of the oxidative stress, and the metabolism was quite clear here. What we didn't show yet was that it was actually mediated by smooth muscle cells, by fibroblasts. So to prove that, we performed a conditioned median experiments where we isolated wild type and knockout fibroblasts from aged mice, cultured them, and gave the conditioned medium to wild type smooth muscle cells. And this led to a reduction of the genes in the contractile genes in the smooth muscle cells, suggesting that fibroblasts were actually causing this in a paracrine way. Now, these data actually led to a sort of a paradigm shift, because this shows that loss of a fibroblast gene is actually causal to vascular aging. And that was actually the lead-in to the VICI project. So I believe that if you want to tackle vascular aging, we should stop looking only at the intima media, but you also should change your focus to the perivascular vascular fibroblasts, and that these can be very instrumental in the consequences of vascular aging, such as hypertension and atherosclerosis and organ dysfunction. So with a team of existing and new group members, we want to reset fibroblast metabolism, and we want to then rejuvenate the aged vasculature in such a way. So how will we want to do that? Well, we'll start by creating a cross-species multi-omic atlas of vascular aging. We've already started collecting the first 5 to 10 human aorta samples of about 80. But not only that, we will also include the aortas of an age-resistant species, the naked mole rat. And after single-cell sequencing and computational analysis, we expect several leads to be there for target selection. So we want to select the targets that are regulating human aging, so we're clinically relevant, that are conserved in the aged primate, because this is a disease-free model of aging, most likely not exactly like in humans. That is also conserved in the aged mice, so that we can do causality studies. And I strongly believe that if the targets also have an opposite effect in the age-resistant species, that this will lead to selection of leads with higher impact. Now, after validation of their expression, these targets will then undergo a series of increasingly complex in vitro causality studies, starting with single-cell cultures, then looking at aortic ring culture for a multi-cell, multi-organ approach and effect, and finally ending up with the vascular function in the myography. And effective leads that are coming out of there will then be studied in vivo, either using genetic models or using compounds to see if they can reverse the aging processes in old mice. Now, of course, reviewer number 3 never likes unbiased discovery. Fishing experiments are not done, although they do drive science, I'd like to add. But so, of course, we also have a targeted approach where we're focusing more in detail on DPAP1, but also some other genes that we uncovered. And with this whole approach, maybe in about 5 years, we hope to have several leads, a cross-species atlas that we make available to the whole community that can maybe also uncover the underlying genes that would drive why some aortas are more or less flexible, and have some leads also to treat patients or do some more studies and finally hopefully to treat patients. Now this seems again like a very simple story, but I hope to show you today that this story shows you today that even if there are unexpected, complicated findings, that it can still lead you to really exciting areas of new research. So, you know, even if it's complicated, don't give up. But I also think that this story could have really ended quite differently. Because if it wasn't for my team and the continuous support and effort of my colleagues here and also in the field and by CARIM, the Research Council, I don't think this project would have been a reality. So I'd like to take a moment to say thank you to everybody. And it also shows, of course, the effort of team science, and I specifically want to highlight the PhD students whose names are in blue for the work on the healthy fibroblasts, and the PhD students and postdocs in red who've been working on the new data with DPEP1 and the aging, and really very pleased to start this project and share with you later some data potentially. Thank you very much.
Thank you. So, are there burning questions from the audience? Okay, burning? No question?
Thank you very much for a very interesting presentation. And in science, we tend to move from paradigms to paradigms, and this is a really nice paradigm shift that you're explaining. But I'm wondering, when we talk about patients, fibroblasts may affect smooth muscle cells, but you show a mechanism in mouse models. How do you know it's the mechanism?
Yeah, so I think that was the $100 million question, and we would need to do many more experiments. I think that there is not one mechanism. I think that would be the answer. I mean, I think Bart and I should join forces and see why these aorta are not the same, and you cannot solve all of these big problems on your own. I do think that this might be a very interesting one. What we try to do all the time is looking whether those genes have a GWAS link, right? So if there's a GWAS link with hypertension, then at least I know it's important in humans, and that there is a chance that if I can revert this DPEP1 activity, which we're trying to do with some DPEP1 mimics, and potentially that could give us some good answers and some good tools to add on top of existing therapy.
Judith,
yeah.
Congratulations again. I've
seen
your way from Veni to Vidi to Vici, seen also the blood, sweat and tears along the way. For me, this is just a comment. I'm not the expert in the vascular field, as you know. We have had 2 talks about vessel wall from Bart and from you, and I see a lot of complementary things where merging your 2 lines maybe even really make the CARIM at the world #1 level in this field. So just a recommendation. And
music to my ears for the next year. But indeed, Bart and I have been talking. We've been trying also with Philippe van Grieken and Koen Racing. We've been trying to share also the tools and the studies that we've been doing, so that if one of us is doing an animal study or getting some human samples, that we can actually share data. So perhaps they are interested in this and we can use that. So we are trying to do this. Sometimes in the, how do you say that, waan van de dag, it gets a bit confused, so we need to restart it again, I think, but I think that is definitely the way to go. Yeah.
Okay, then I'm going to close this session. Thank you for this inspiring talk. Frits, thank for the inspiring question, I must say. And then I think I give the word to the next moderator, Leon.
So now we are switching gears a little bit from content to platforms. I was asked to introduce Dr. Armand Jaminon, who's working at the Department of Biochemistry, and he was selected by CARIM to represent us as institute in the KBM2, which is the knowledge platform of biomedical models in Maastricht. I don't know where the 2 come from, because I count 3 M's. Armand, I think you will enlighten us what this virtual platform is and how to bring together within FHML, all the institutes, all the knowledge and the technology in a kind of virtual platform.
Hello all, I see I have to open my presentation. Yes, thank you Leon for this nice introduction. Indeed, I was asked to give an update or an introduction in the KBM2 initiative. I think it's not really known yet. I suppose at least that it's not really known yet. But I think our director last week sent a nice email with a request to fill in a questionnaire about this. And I also urge you to do that, please, for us, because that information that you will give in that questionnaire we can use to build this system. And I'm now going to explain the system. So, what is it all about? It's all about biomedical model systems that we have present in the MUMC+, which in this case you can see it can range from genetic models, cellular models, in vitro models, in vivo models, but also human models that are used in the clinic. And all of these models, they are set up or they are invented by researchers that are actually present in our university, but also between different institutes. And of course, I am the one that will talk about it for CARIM, but this is an institute-broad approach, so it means that all the institutes that are in FHML are part of this KBM2 initiative. And to support these institutes, we also have research facilities such as Scrum, CPV, MURMM, and ID to help us achieving our goals, so to build models that are valid. But the university recognized that we are quite good as Maastricht University in our translational models. And the idea of this initiative was to increase the impact of our models in research, which we already do, but also in clinic and in education. So then, if you want to increase the impact of the models that we all have, I think we need to determine what factors drive this impact. And I split it up into 3. So if you look at research, for example, I think impact can be reached by a broad applicability. So not only using your model in your own area of research, but maybe a colleague, collaboration we just talked about as well. We heard you did talk about it. If you can use it in different fields, that would make a much larger contribution. Of course, innovativeness and uniqueness is, and I think, as well important, so that you have the best state-of-the-art model that is there, actually on the market or in research. In the clinic, I think what we always want to make, so to make it translatable, is representativity. So it should represent what the problems that we find in clinic. So the preclinical model should represent the medical problems, and it should be translatable as well. And in education, it's a little bit off topic, I think, but I think it's also quite relevant. I mean, the curricula nowadays, they don't always often include all the models that are present in research. So I think it's also key that we can contribute there in implementing these models in education, and also continue this for novel developments that are arising. But to define this impact, we also need information about what actually do we have present here. So we have some questions that we need to answer. And I see indeed that this mouse thing is not really working, but anyway. So in research, these models, it's all depending on, is a researcher willing to share the model that they have? So availability or accessibility of the model is, I think, key to start up collaboration. Also, does a researcher always use the state-of-the-art model that is actually known in literature? I mean, if I speak for myself, we often are used to models, and we will use them, but are they still state-of-the-art? This is the question that we need to raise, I think, as a researcher to yourself. Is my model that I use state-of-the-art, or are there nowadays new models, and should we get these new models present, or is there someone in my university that has this model present? And why cannot we collaborate once we know this? And I think this is still a little bit blurred. We don't know all of this information yet. So for the clinic, models that are present there, are they valid? Is it also the state of the art that we are doing? So it is really key to connect, I think, the preclinical work to the clinical work, so that we develop the models that represent most or our state of the art. And then for education, so what models are already included in our curricula? We are sort of inventorizing this now at the moment, and what should we add to this curricula that we think is very important? So these are aims that we have as the KBM2 initiative. So how are we going to do that? So the first step in our initiative is that we will set up a database where we collect all the models that are present in our institute or in our faculty. It means that we want to collect all the biomedical models at MUMC. And for that, we are going to build a digital catalog with some information present, and we want to keep that also up to date. So that means that it should constantly be, information should be added. We do this in collaboration with the MEMIC, so that's the data science part of FHML. But what do we then need as information? And this is all stuff that you need to provide us with. So what is the current application of the model? Can you broaden it? Is it state of the art? Is it valid? And has it a translational potential? So indeed, so we are always quite busy, and I think we need to look at whether the model that we have is the best that we have. So with the wheels, if you don't look that there are wheels and you're just going to continue struggling on, that's not the best way. So I think we should really collaborate to each other, and we hope with the database that we sort of can find each other in a better way. Not only within CARIM, because I think we're already on a good track within CARIM to finding each other, but also within the institute, so in the FHML, in the faculty. So these are just some extra points. So we want to connect people up so that they can find their models in a better way, stimulate and propagate innovation, cultivate and optimize and facilitate these new models. And for that, like already was introduced, the faculty decided that there is this initiative which is called Knowledge Platform Biomedical Model Systems Maastricht, and double M is for Models and Maastricht. I didn't think of the name, but that is the name at least. We also have an employee page, so please, if you want to look for updates on this, find our employee page. But what are we actually going to do then? So we want to create this platform, so this database. We want to stimulate or facilitate that researchers connect so that they can indeed collaborate on the novel models that are present. We want to increase the quality of the model systems by looking at innovation, validation, translation and valorization. And I think valorization is an extra pillar. There is a lot of tools online available, for example, that can validate what you are doing is actually right for research, for clinical research. We want to structurize this. We want to make this into some sort of a stream system where you can find the ideal setting to make sure that you are doing a valid research. Then also, regional integration of the systems in the curricula is for us important. And once we have this established for the faculty, the idea is to broaden this towards the university. So meaning that we include other faculties, but the start now is for FHML, but we could also think of PNN or FSE, which are also science faculties, I would say. And then if that would be set up, we could go nationally, so talking to other partners inside the country or even go internationally. So the blue abbreviations that you see here are mostly they are committees looking into animal-free work, using other systems to work with an accurate model. So these are these abbreviations. And then there will be a soundboard committee. So on the short term, I think what we want to achieve is that we can increase researcher output by connecting them to each other, also improving efficiency of research, just because you have this model now available that is present in our university. Maybe work together and try to use the models that are there to spike new collaborations and new funding opportunities and accelerate towards application of these models. And if you would look at the long term, I think we want to, of course, expose ourselves more, that we are internationally more visible, positioning the UM as an incubator for model systems, but also join maybe international activities on this. But another important pillar, and that's the last one, I think is also the integration in the UM curricula, which I think is so far quite marginal. So we want to really put effort to this as well. And as I said, I am the one that was chosen for CARIM to represent. These are the other people for the other institutes that are presented or chosen, and it's all chaired by Ramon Lange, who recently, or not actually recently, became professor, but he is the chair of the committee. So these are the people. So if you want to know more about it, you can come to me, obviously, and we can talk about it. But with that, I want to close it off already. This is the link to the questionnaire, but it's already sent around as well. So use the link in the mail of Tilman that he sent us. We would really appreciate this information that if you put that in, so that we know how we have to build this database for you, because we do it all for you actually. Are there questions?
Thank you, Armand, for this very clear presentations. Other questions? Bart.
Hi, thanks. What do you mean by model?
Yeah, this is the one I anticipated indeed. So we don't consider per se methodology as model, but really models to study a disease. For example, in my case, in my own experience, I would say an LDL receptor knockout mouse or ApoE knockout mouse, that would be the model to study atherosclerosis in the disease. But it's a bit vague. I agree with you, so we have to, I think, make that more clear in this database. But this is what we are now aiming for, and there's also the input that we want you to give to us for what would you see as ideal to put in this database.
Okay.
So, but next to this model system development, we are also looking into what machines, what is the hardware that we have present that is maybe also not known by everyone that we can actually use between groups. But that is a side aim, but it's not the initial aim for the initiative at least.
Okay.
But model systems is more modeling of disease.
Okay, thanks.
Or other.
And follow up, that is also for clinicians, for clinical research, how do you see that as what models are available there? We have a ward full of patients, but...
I think you know better than me.
No, but I see like how can you then deliver a model if you're doing clinical research to this? Because I really believe in the translational collaboration and everything, but how do you see then clinicians filling in this form?
I think they do, I mean, maybe for CARIM it's a bit more tricky, I would say, but I think part of the initiative, they say we have ischemia reperfusion models that are actually done in patients, and what they check there. So this would be a model that is more clinically relevant. For CARIM, I have to honestly say, that is, I don't know yet. I think we need to talk to you, the clinicians, because what we want to achieve is, I think, a model that is best translatable to what we find in the patient, so what the patient encounters. Can we model that, and how can we model that in the best way?
Armand, I also have a question.
Yes.
Is there also money available? Because with each platform and each expertise that we build, it's always nice that you have the machine, but if it is not steered by an expert person, then it's useless. So
but
is FHML also investing in the platform?
So you mean more that the models that are there are supported, or
yes.
or
yes.
the
Is there
people
also
that
supportive staff, for example?
Yeah, I think for this KBM initiative, no. So it's really that we will build this database and see. It's not that that we have an NMR facility that is guided by staff and that is kept up for everyone. I think this is still distributed towards the institutes, right? Yeah. So this is still money that needs to come from the institutes. And I look now at Tilman, but I think...
Yeah, well, I've seen that platforms are, let's say, created and that we have to pump around money and ask fee for service, which I would like to avoid. So maybe FHML and maybe the KBM2 can...
But for now, from the initiative, there is only money available now to build the database, but nothing more. Yeah.
Thank you. Very important presentation, I think. Following up on the question of Kevin, there is, of course, a gray zone here, and that is in the epidemiological and the population models. Population models play an increasing role also in understanding disease. Things like Mendelian randomization can be very useful. So is that also meant by this? Because I think
yes.
that, yes.
I mean, I'm not sure how we should integrate it yet, but I think it's very important. But this is stuff indeed that, as you highlight, this is something we maybe oversee as our committee, So it would be really detrimental that this kind of information would be available to us so that we could include these kind of models. I guess there are computational models that look into this
yes,
topics
and
as
then
well.
the step to data sets of large epidemiological studies is of course very small, and often this is linked to each other very intensively.
Yes. Yeah, so
this may be a little bit too far, but I think that leaving out population data sets would be a limitation of such an inventory.
Yes, also because probably the research itself wants to protect their own research, right? I think, at least. But I agree. The more we can share, I think the more we can benefit from each other. It doesn't necessarily.
But do you expect researchers also to include such information into that?
I would say
inventory?
yes.
Okay.
So it's still out. That's maybe good to mention. So the database itself is protected by SURF so far. So only people that have a SURF account can access it. So that would mean all universities so far. But I mean, now it's built locally first. So that's also why we build it locally first, because we want to first see how that does it go before you provide all that information out in the world, right? So that would, in the first step, we want to protect that a bit. But the idea is, yes, that we take this broader. But first, the steps, SURF is now the golden standard. So if you have a SURF Connect account, then you can enter in this database, and then it's also verified. Also, for example, the idea is that if you provide information into the system, this is checked by the PI. It's not that you just put it there and it's there. Sure. So these are steps that we take into account, yes. But the idea indeed would be to share knowledge. So I would say that that would be included, or that can be included.
More questions from the balcony? I can try to throw it up there. If not, thank you, Armand. I think you're around if people have questions.
Yes, you can ask me.
Perfect. Thank you.
Yes.
Who takes over?
Ja, dat niet eens. Ze hebben het gedaan, dus we moeten hem even opnieuw openen. Waar ligt hij? Op deze man. Toch even hier en de tab en de enter en dan boom. Yes, okay, great. So we are really happy to have gotten the opportunity to provide a new initiatives for award for PhD students, and we're really lucky that Danny and Tilman agreed with this. So we want to introduce you to the CARIM Robert Renneman Young Investigator Award. And what is the CARIM Robert Renneman Young Investigator Award? I think we introduced this award as part of the team of CARIM for PhD candidates to help them in their future career. We have seen today how important it is to get grants like the COSTA or maybe Iavini in the future, and we hope that this award can help PhDs in their future. It also offers an alternative opportunity instead of the Haas-BAFTA, and which is required for PhDs to go abroad. And I think it's also really nice to enable PhD students to also showcase their work here doing the overall CARIM Symposium program, as it has been highlighted a few times today that collaboration is important, and I think it might start with collaborations between PhDs from different departments. We have, for this year, it's the first year that we introduced this concept, and we are really lucky that we received 17 PhD candidates that applied with their abstracts, and we were, with a really nice review committee, 5 PhDs were selected in the second round, in which they have to provided a pitch, and eventually 3 PhD candidates were chosen to present their work and showcase it here during the annual CARIM Symposium. And I also want to say that we only have winners today because all 3 PhD candidates, they get a prize. The first one gets a prize of 2,500 euros, and the second and third one also a prize of 500 euros, which they can use for research purposes. So think of a conference or a course or even lab materials. And we also have a really nice certificate, and to which I want to thank Tara, Esther, and Barbara for which they made for this Investigator Award. And this award was named after Professor Robert Renneman, and I think most of you know that this was the founder of CARIM, and I hope he's there online because he can sadly not join in person.
Obviously, I knew that this was also going to be a nice opportunity for people to present and showcase their own work, and it would become a success. As my own supervisor also said, like after the email was sent out, hey, maybe join. I figured, as I'm also co-organizing this with Lisa, I figured it would not be really ethical to also participate in this event myself. But we do want to also thank for this bit of being unbiased. We have collaborated with 5 other people from different academic levels, from different departments, to ensure that we have a very rigorous mindset and way of evaluating all the abstracts and pitches that we've seen so far. I will briefly just showcase the presentations to be given. The first one by Anouk with the optimizing screening for transthyretin amyloid cardiomyopathy serum transthyretin to select patients for screening. The second will be given by Ilse. She will talk with the seeing the unseen of lenticulostriate, difficult names, arteries on photon counting CT. And lastly but not least, piezo and smooth muscle sulfate and cerebral small vessel disease by Eileen Boller. I want to highlight also one part as the audience where you guys have a part in it as well. Hopefully, if you're willing to use your mobile device, scan the QR code to participate in the ranking of the candidates. You are given the opportunity to give them a grade from 1 to 4. And that will be taken into consideration for the final grading for the winner and the runner-ups. Please be not too biased with your own group, but otherwise be nice. We would like to welcome Anouk for the first talk.
Yes, good morning everyone. It's great to see you all here today. My name is Anouk, and the goal of the study I will present to you today was to optimize screening for transthyretin amyloid cardiomyopathy. So amyloidosis is a disease in which proteins will misfold, become insoluble, and form amyloid deposits or fibrils in various organs. And in transthyretin amyloid cardiomyopathy, the protein involved is transthyretin, also known as prealbumin, and synthesized by the liver. And it will form amyloid deposits between cardiomyocytes, leading to heart failure. An early diagnosis of transthyretin amyloid cardiomyopathy is really crucial, because current available therapies can only slow down disease progression and slow down the formation of new amyloid fibrils. So if you have more advanced disease and more cardiac involvement at diagnosis, these therapies will be less and less effective. So current guidelines therefore recommend to screen a broad population of heart failure patients to range from heart failure with preserved ejection fraction to severe aortic stenosis. And this means that in all of these patients, you should do a bone scintigraphy and in some even a cardiac biopsy. However, routine screening of a broad heart failure population, such as heart failure with preserved ejection fraction, is controversial. And this is because of the modest diagnostic yield and a large number of scans required. So, motivated by the need for more simple and accessible tools to screen patients for transthyretin amyloid cardiomyopathy, I hypothesized that serum transthyretin, a routine available biomarker, also known as prealbumin, can be used to screen patients for transthyretin amyloid cardiomyopathy. And this idea came from the fact that when you treat patients with a transthyretin stabilizer, they start with quite a low serum transthyretin value, but it can increase quite a lot. So I thought, okay, if transthyretin will misfold, its concentration will decrease in the bloodstream, and that I can use to differentiate with other heart failure causes. And this idea led to an international collaboration with the National Amyloidosis Centre in London, and I was able to establish this after receiving the HS BAFTA last year. And what we did, we compared serum transthyretin values between patients with, of course, transthyretin amyloid cardiomyopathy, but also heart failure patients in whom amyloidosis was excluded. And what we found was that serum transthyretin was indeed significantly lower in patients with transthyretin amyloid cardiomyopathy. However, as you can see, there was also quite some overlap with control patients. And this makes that if you want to use transthyretin on its own to diagnose transthyretin amyloid cardiomyopathy, it will have a modest diagnostic performance. However, I was able to identify clinically relevant cutoff values that can help a rule in or rule out strategy for further diagnostic evaluation. So if you have a serum transthyretin value below 0.25, that was the optimal cutoff value, I would argue that you should do a bone scintigraphy. And the sensitivity of this was 72% and a specificity of 65% in the validation cohort. If you have a very low serum transthyretin value, the specificity goes up, but your sensitivity goes down also quite a lot. On the other side, if you have a really high serum transthyretin value, you can reliably exclude 13% of your control patients. So you can say, in those patients, I don't need further bone scintigraphy. So serum transthyretin can be used to select patients for further diagnostic evaluation, and this approach can improve early diagnosis, but mostly the overall yield of screening for transthyretin amyloid cardiomyopathy. So I would say, at the end of my PhD, the sun shines bright at the horizon, and I would love to validate these results in other heart failure populations and also test this prospectively, as I will do so as a postdoc. Thank you very much.
Thank you very much, Anouk. Are there any questions? Ooh. No. Okay.
That's easy.
Yeah? I suppose we can just head on to the next one. Thank you, Anouk.
Perfect. Thank you.
Yes, I'm Ilse Huiberts from the CARIM division of blood, and I'm pursuing my PhD under the supervision of Dr. Jacobi, Professor van Oosterbrugge, and Professor van Zwam, and thank you for this opportunity. So this talk is actually about seeing the unseen, because what we can't see, we can't treat. And this is especially true for the smallest cerebral vessels, such as the lenticular arteries. They supply the basal ganglia with blood, which are crucial for movement, cognition, and reward. Because they lack collateral blood supply, they are extremely vulnerable for occlusions, and even the smallest occlusions can lead to often serious and irreversible damage. Yet, with the current CT and MRI techniques, we can hardly visualize them. That's why our research aimed to explore a new and non-invasive imaging technique, which is the photon counting CT. This is a new CT scan that actually has a different detector than conventional CT scanner, that makes it able to visualize small cerebral vessels with more detail while producing less noise and also using less radiation. And therefore the aim of our study was to compare the photon counting CT with the DSA, which is the digital subtraction angiography and currently the golden standard for the visualization of such a small cerebral vessels, but this is an invasive procedure that carries risks. And also comparing photon counting CT to the conventional CTA techniques. We did this in a single center retrospective cohort study here in Maastricht, and we used subarachnoid hemorrhage patients between 2021 and 2024, and we chosen this population because they routinely undergo both CTA and DSA as part of standard clinical care, and their lenticular arteries are presumed to be intact. And two experienced radiologists independently evaluated all the CT and DSA scans for the presence, the number, and the length of the lenticular arteries. And of course, they also looked at parameters for image quality, such as venous filling. Of course, due to the time, I cannot show all the results, but let's start with the visual results. Here in this left side, you can see the DSA, and the DSA actually has 3 subtypes of imaging. And on the right, you see the photon counting CT, and the green circle indicates the lenticular arteries. But when we put this into quantitative numbers, we look separately at the right hemisphere and the left hemisphere. And what you can see is that actually the presence of the lenticular arteries, so simply detecting them, is comparable on photon counting CT versus the DSA. And is also not statistically significant difference. But when we look at the length of the lenticular arteries, the DSA is able to show the more longer segments of them, with 41 millimeters versus 25 millimeters, for example, in the right hemisphere. As I said, we also compared the conventional CTA techniques with the photon counting CT, the second and the third generation. And you can see that already on the visual, that the more longer segments are visible with the photon counting CT. And also when we put this into numbers, we see actually that the photon counting CT is superior in all dimensions and is also highly statistically significant. So to conclude, the photon counting CT can detect reliably the lenticular arteries by comparing it with the DSA and the conventional CTA techniques, but the DSA is still able to show the more distal segments of these small arteries, which is likely due to the direct intraarterial contrast administration during this invasive procedure. And our next steps are first to, of course, validate the photon counting CT in a prospective cohort. And the second point we're really excited about is we want to look in an ischemic stroke cohort to see if we can detect occlusions in these small lenticular arteries and connect these to patient outcomes. Because what we now see is that sometimes patients with large vessel occlusions get a timely and technically perfect endovascular treatment procedure, but still do not recover at all. And we think that occlusions in these small arteries can be the reason for that. And we can then also develop new treatment targets, such as intraarterial thrombolysis that grabs on directly into this microvasculature. And of course, I want to thank the co-authors and thank you for listening.
Now, before I ask about questions, I do have one already. So regarding on the more practical side, what makes you want to change from the original method to the new with the photon counting? What, aside from it was less invasive, I understood? Or?
Yeah, of course, the photon counting is just a CT scanner, so it's actually non-invasive. And also available in acute settings, while the DSA maybe sometimes also for other diseases can be skipped if the photon counting CT is reliably enough to show certain diseases like ischemic stroke, but also like subarachnoid hemorrhage patients, for instance, with aneurysms. If the photon counting CT could detect that reliably, then the DSA can be skipped.
And the device is something that's available in multiple centers, not just Maastricht or?
Yeah, here in the Netherlands, I think at 4 centers,
okay.
But they're also improving that.
Okay. Yeah. Any other questions? Oh.
Then maybe one you still have. So I think your results are based on 2 radiologists who assess both the photon counting CT and the DSA. So do you know the interrate reliability between those 2?
Yes, the interrate reliability was up to moderate for the photon counting CT and the DSA, and it was really poor for the conventional CTA techniques.
Okay. But between the 2 methods that you compare, they were the same. They were moderate. Yeah. Okay. Any other questions? No. Then I think we can proceed to the next.
Okay, so good morning everyone. I'm Melien Bolle from the CARIM division Blood, and you may not recognize me because I'm a joint PhD working together with Leuven and Maastricht. So my first 2 years were in Leuven, and now I'll be joining you guys in Maastricht for my last final years. And today I'll present to you PSO1 and smooth muscle cell fate in cerebral small vessel disease. So dementia affects more than 55 million people all around the world, and 1 in 4 cases of strokes are caused by small vessel disease. Cerebral small vessel disease is a leading cause of dementia and stroke, and is a very critical and indirect risk contributor to this cognitive decline. However, we don't fully understand how or where it truly even begins. What we do know is that there is a remodeling of the small vessels in the brain, such as the arterioles, the capillaries, and the small veins, and that the onset of the CSVD are linked with the cardiovascular comorbidities such as age, hypertension, also diabetes. And a very important one is hypertension. So with this hypertension, you have a chronic high blood pressure, and there will be therefore a higher pressure on the walls of these vessels, which can make them more stiff, and there will also be changes in shear stress in general. So we can actually say that CSVD, or cerebral small vessel disease, is not only a vascular disease, but also a mechanobiological disease. And we are very interested in PSO1, which is a gene that encodes the mechanosensing ion channel, and it's maybe to see if it's a key player in this vascular remodeling. You may know or recognize PSO1 from the 2021 Nobel Prize in Physiology and Medicine, where they discovered the very important role of PSO1 and also PSO2 in sensing the mechanical forces. In order to assess the role of PSO1 in these endothelial cells specifically, which are the cells aligning the blood vessel, we use a hypertensive mouse model. And this will be used for both wild type and knockout conditions, specifically for the endothelial cells specifically. And first what we did is to look at the brain perfusion in general, which is done by laser speckle contrast imaging. So what we first found is that with hypertension, the cerebral blood flow would go down, which we expected. However, what we didn't really expect to see is that if you knock up PSO1, specifically in these endothelial cells, there will be a higher cerebral blood flow in general. Okay, with this in mind, we're wondering how could this be? How could this blood flow be higher in this PSO1 deleted mice? So we're maybe thinking, oh, maybe the diameter would be bigger. That's why I did immunohistochemistry staining to look at the diameter. We didn't really find a difference in diameter. However, we did find that there is a thickness, like decrease in thickness of the arterioles in the PSO1 deleted mice. So with this in mind, I suggested to look more specifically at the vascular smooth muscle cells because they're very important in this remodeling. So I propose to first of all look at the number of vascular smooth muscle cells to see maybe if PSO1 is also important in this reduction number of vascular smooth muscle cells, for example. And secondly, I also want to look at the phenotypical switch in these, to look at the phenotypical switch to see if there is maybe a shift from contractile to a more synthetic phenotype with these PSO1 deleted mice. And lastly, I also want to do an in vitro study to look more specifically at the signaling mechanism between these endothelial cells and the vascular smooth muscle cells. Prof. Redemann's work leads to a foundation for understanding the microcirculation in health and bone disease. And with my work, I want to really look at the cerebral microcirculation in small vessel disease and hopefully get a deeper understanding of this microcirculatory regulation and its role in the cerebrovascular disease. Thank you very much.
Thank you very much for your presentation. I have one small question regarding, you talked about synthetic and contractile smooth muscle cells. Have you already checked for some single cell data sets out there that differentiate between these two cell groups and you see if PSO1 is up or down?
Yeah, there is a single cell data set that I want to look at. I'm working on it now to see if maybe PSO1 is upregulated or downregulated in these smooth muscle cells. But I also want to look more, of course, in the notch pathway or other kind of pathways, but I'm working on it.
And do you know already something with PISO1 specific, more in a broader context of cardiovascular disease like atherosclerosis or aneurysm, if there, it plays a role in there?
Yeah, of course, it also plays a role in these kind of like the more vascular disease, like cardiovascular diseases. I think it's just in general very important for the mechanosensing and the blood flow in general. So it's also very important in these kind of diseases.
Okay. From the audience, one more.
Thank you. So endothelial cells have a lot of different mechanosensors, right? PIAZ1 is just one of them.
Yeah.
So do you think the effect on hypertension is PIAZ1 specific, or this is rather pan-mechano influence that you see?
Yeah, I don't think it's really PIAZ1 specific. It's more like if PIAZ1 is, for example, knocked out, there are mechanological pathways that are involved. So I think it's more like the link between PIAZ1 and these other pathways.
Thank you.
Thank you.
Hi. So you also mentioned that age is a big risk factor for cerebral small vessel disease. I'm wondering, these mice are quite young. Do you think that the effect that you will see, that it will be higher or more impacted if you look at aged mice with this knockout?
Yeah, it's very interesting to see. I think the effect would maybe be higher if you have older mice. But for example, we already see now that there is a difference. So I think, yeah, maybe if they're older, they have a higher difference. Could be, yeah.
That was you.
Hey, thank you very much. Very interesting presentation. Just wondering what the function could be of PIAZ1 on endothelial cells, because I can imagine in a smooth muscle cell, it would be maybe in part like that calcium influx could trigger this myogenic response, which would make sense. But I'm just wondering, what does that calcium influx do in the endothelial cell that you think that could affect that vessel wall in general? Like, what is that mechanism?
Like the general outcome?
Yeah, what is the role of a PIAZ1 channel? Like, let's say it's activated by shear stress of stretch or compression even. Like, you'll get a calcium influx in the endothelial cell. What makes you then say, okay, we're going to look at endothelial cells? What is the function of that calcium influx on the endothelium?
Yeah, the calcium influx, it causes like a mechanical pathway to go through, of course, for example, also with the smooth muscle cells and or with the parasites are also important. So that's, it's like a trigger to follow like the cascade of pathways that follow through that are important for vasodilation or like just the blood pressure in general in the brain, for example. So yeah. Thank you.
Okay. Oh. Yeah. Oh, good time. I will take care of it. Yeah. Yeah. Thank you very much for your final presentation. And like I said, indeed, I will go to the final QR code again, so that those that had not done so can scan it. All in good time.
Yes. Yeah, so you have the opportunity again to scan the QR code. We will announce the winner at the end of the CARIM Symposium, and we will take these scores together with the scores that they received for their abstracts and their pitch rounds and add them all together.
And I think, seeing the schedule, we don't have anything else scheduled now, and I guess we're a bit ahead of time, but I suppose we can go to lunch, right?
Leave it there, yeah.
We will leave it up here, and then you guys can come by whenever you need to. Yeah.
Why did that leave?
Okay. Good afternoon, everyone. Yes, I see some people on the balcony that still need to take a seat. Well, welcome back, everyone. Well, normally it's quite a challenge to give a lecture after lunch, but I'm absolutely sure that this will not be the case for this speaker because of the topic of the lecture, and also it will be very interactive, as I heard. It's my great pleasure to introduce the next speaker, Patrick van Veen. Patrick is a renowned behavioral biologist. He studied biology at Utrecht University, and he's widely known for his ability to translate complex scientific insights about human and animal behavior into clear, engaging, and often eye-opening stories. With years of experience studying social dynamics, both in primates and in human organization, Patrick has developed a unique perspective on how we interact, cooperate, and sometimes clash. Through his research, writing, and lectures, he has inspired audiences across disciplines to look at behavior, especially in organizations, through a new lens. And today he will share his insights with us here at this CARIM Symposium with his lecture entitled Monkey See, Monkey Do. Please join me in welcoming Patrick van Veen.
Thank you, Ingrid. Thank you for this introduction. Yeah. It's always good for me to have the opportunity to sit there in a corner and to observe you, especially to observe you when you find a place. And I was just sitting there and thinking, okay, what type of audience is this? And I immediately thought, okay, every behavioral biologist studying social groups would say this is an academical group, because you have the behavioral patterns of an academical group. And I will explain that, because you do a few things you never will see on other conferences. When this would be a conference of financial experts, you would see different behaviors. If this would be a conference of NGOs where I'm part of, you would see different behavior. But you see typical behavioral patterns that are linked to your profession, but most important to the environment where you work. I think a few of you will get curious now, but don't worry, I will explain. So I'm a behavioral biologist. My normal job is to study primates and humans. But the most important thing for me is trying to understand why people act in the way they do. Why do we show behavior? Why do we manipulate? Why do we like to play power games? Why do we bully? Why do we withholding information? And it sounds maybe as a very negative thing, but a very famous management guru said once, if you want to influence behavior, or when you want to change behavior, the first thing you should start to do is understand the behavior. So why do we show that typical behavior? And I'm going to take you today in my environment to explain something about our human behavior, and I hope also something about social dynamics in your environment. I will talk about cooperation, but most important, just about our own behavior. So I hope also to inspire you today to look into the mirror. And I was just in the bathroom here, just going to the toilet, and I saw there are a lot of mirrors. So I would say, after my lecture or during break today, take an opportunity to look into the mirror and think, okay, what primate is looking at me, or what primate is staring at me? So I'm going to talk about primates, and don't worry, I understand these are not primates. These are wildebeest, and these are very specific wildebeest on the Serengeti. And this is part on what we call the Great Migration. And maybe some of you have been there and witnessed it. Maybe you have seen documentaries about it, but you have to imagine there is a herd of 1.3 million individuals. And they are circling around the Serengeti. Every year, the same routing. And think about it, 1.3 million, 1,400 kilometers every year, over and over again. And what is so interesting is that ahead of that group, there is a small group of wildebeest, maybe 10,000, maybe 15,000, 20,000, we don't know exactly. But they can smell rain. They smell rain on a large distance. They can smell rain over a distance of more than 25, 30 kilometers. And so what they are doing, they are just heading to the rain, and so heading to food. But more interesting is this group of more than 1 million followers. They don't smell rain. Any clue what they smell? Yeah, shit. That's what they smell, manure. And when you have been there, you smell it. But they still trust that just walking behind the ass of the others will bring them to the right spot. And the reason they do that is because they are extremely lazy. They're saving energy. They don't discuss. They don't say, let them go, you know, I take my own routing. Maybe there is better food. No, they just follow the step in the manure of the others. And interesting is, this is what we do too. A lot of us are showing behaviors because we are used to do it. A lot of us do the things in a way, not because it is the smartest way or the best way, but we just do it because we are used to do it. And it's very difficult to step outside the herd and think, no, I'm going to do it in a different way. And if you don't believe it, please go on a Saturday afternoon into Maastricht and just observe people. It's like a herd. People are massive, walking behind each other, buying stuff they don't need because others are doing it. And that makes it very interesting because actually we humans are not herd animals. We are not like the wildebeest. A biologist would say, no, humans are like chimpanzees. They are a troop. And interesting in primates is that everybody makes a decision for themselves. They really make their own decisions and not as this huge herd. The only thing is humans, we are always in the middle of that. And that has to do because we have a different social structure than primates have. But in our brain, we should be able to make our own decisions. But then still, we do a lot of stuff we did always in that way. And one interesting point is, for example, we had COVID. And I do a lot of lectures on an annual basis. And during COVID, I really got to believe that when COVID would have gone, we would start symposia, conferences in a different way. And I would not say that we would start to meet online, but I would say, you know, a conference we will start 11 o'clock in the morning. It's much more comfortable because when I have to be in Utrecht at 11 o'clock, you know, no traffic jam, you can sit in the train, and it's much more comfortable. And then we continue just until after dinner, so until 8 o'clock in the evening, have dinner, and then we go home. COVID was gone. Most conferences still start at 9 o'clock. 9:30 we start with the first presentations. And okay, when it's 5 o'clock, we get nervous because we want to get home so that we can have the peepers at home. Peepers, for English-speaking people don't know what it is, the potatoes. Yeah? It's we want to be at home for dinner. So we went back to what we are used to. And that's for me very interesting. So I hope that you also start to discuss today what is in your behavior which you say, no, it's really the best way or a practical way or the way we should do it, or are you showing behaviors just because you're used to do it? That is, for me, always a very important question to raise. So these are my colleagues. They are going to help me today in my presentation. They are going to help me to explain something about social behavior. So I hope that you can recognize a few of your colleagues here already, but I will also explain a little bit more about them. So I have a few questions for you. What is for you leadership? Who can answer that? What is for you leadership? Or just yell out loud also upstairs there. Being an example. So going? Knowing your team members. To be very honest, I see in a lot of organizations, some leaders have so many team members, it's impossible to know them. But it's a very crucial one, I think, key element in leadership is knowing your team members. Being a facilitator, yeah? Taking initiative. Confidence. For whom? For the leader or the individuals in the team? Yeah, absolutely true. Leaders need to have or need to be confident, so individuals in the team can have confidence in the leader. I know a lot of leaders who have zero confidence, I can tell you. Yeah? Representing the best interests of your team members. Very nice one. So, I think when we do research about leadership, one key element we see in biology is the importance of having leadership is saving energy. So if you have a leader who costs you energy, delete it, because that's an incompetent leader. Leaders need to save energy, because the very simple reason for that is if you have leadership, and I think everything you just said is absolutely true, but it results in saving energy. Because if you have a leader that facilitates, a leader that is an example, or showing the direction, a leader who knows his individuals, a leader who knows also what is the environment and what direction are we going to. So if a leader can show that, it saves energy because you don't need to discuss it with the whole team. It is very nice to have everybody involved, but if you do that in every small decision, it is a huge waste of energy. So leadership is mainly also focused on really being an energy saver, I would say. What does the word trust mean for you? What is trust? What is the basis of trust? Integrity? Yeah, I can say people are not integer. Its integrity is crucial, but key element is people are not integer animals. Integrity is just a fake idea in humans. There is an illusion of integrity, and if you can show that, that's okay. Yeah, of course you can show behaviors that are linked to it, but the reason I say it's so direct, at any time, if you have to choose between your beloved ones and an individual you don't know, most of us will always choose their beloved ones. And that's nature. That's how we are programmed. So in decisions that can bring profit to our beloved ones or to somebody we don't know, most of the time we choose our beloved ones. And of course, there is what is it the choice about, but there is a challenge in that. So integrity, I don't argue. I think showing the illusion of integrity is very crucial, but it's good to have that discussion. It's very important to have that discussion. What else? Liability, reliability, reliability, communication, safety. Honesty, we said honesty. Yeah. Forget it. Humans are not honest animals. Oh, this is getting weird. No, but honesty is no, to be honest. Yeah, we can even trust people who are never honest. As long as they are consequent liars, we trust them. Yeah. Good experiences. There is here sitting somebody who was screwing up my presentation because he said predictability. That's it. Predictability is the most important key element in trust. As long as we can predict people or animals, we trust them. I say it very blunt. If your colleague is an asshole, it's okay. As long as he is a consequent asshole. If you're having an agreement with somebody, but he never shows up, you can trust them. As long if their behavior is predictability, or if there is a certain predictability in their behavior. And that makes that also negative behavior can lead to trust, as long as you know that it is negative behavior. We really don't like people who are, one day they come up and say, okay, no, this is what we agreed, I'm here. Look, I'm doing what we agreed on. And the next day, they don't show up. We don't like that. Better never show up, because then we know what we are up to. And the reason I question this is because these words are key in current organizations. But it's also important to be aware about how things work in our brain. And the last word, and then I continue to the primates. What is cooperation?
I think it's sort of an agreement that if the people help, or the individuals help each other out, that both will profit. I think that is sort of the silent agreement that is in the process called cooperation. That is how I would define it.
Yeah, and I like that definition. So it's silent agreement that when we cooperate, there is a profit out of coming, and both of them have a profit out of that. Efficiency. Yeah. There is a win-win, and maybe we can do something that makes a process more efficient. We don't double our processes. I see sometimes the opposite in organizations, that we start a cooperation and we get less efficient. Then we maybe should say, stop that cooperation. But then we are herd animals again, and we started once a cooperation, and we just continue because we have that cooperation. I think a lot of cooperation you couldn't stop tomorrow, because it doesn't bring anything to anybody. No profit, no efficiency. But because we did it and we started it, we just continue to do it.
It's all about saving energy. So leadership, trust, and cooperation.
I think that's the summary of my talk. Yeah. It's done. Yeah, it's saving energy. It's a summary. And the reason I talk today also about cooperation, because one of the oldest scientific papers on studying primates, chimpanzees, talking about chimpanzees showing behavior that was really researched to understand human behavior, that was a paper from 1921. And that was written by a Professor Köhler in Göttingen. He had a research station on Tenerife, and he was studying chimpanzees. In the intelligence Prüfungen of chimpanzees, he had a very nice word of that paper. And he was studying to understand human behavior, but he used chimpanzees to understand it a little bit better about how humans cooperate. And I will show you the experiments he started with. And I think that's the basis where a lot of research later on started. So I'm going to talk about primates, and why primates to explain something about human behavior. So in 1921, this Professor Köhler, psychologist, started with studying primates. Later on, a lot of researchers, François, Jane Goodall, Diane Fossey, all study primates to understand human behavior. And the reason we do that is because we are very social animals. Humans are social individuals. You have social agreements. So when I look to you, I see a lot of people sitting in a very nice, socialized way. I don't see anyone sitting like this, putting their arms or the hands on the knees of the neighbor. Everybody respects everybody's environment. Why do I say this is a very particular academic environment? It's because the number of people sitting with a space on both sides is larger than in a different conference. So I see here people sitting who can use more space. And that's very typical when you see an academic environment where people are just taking their space. It's weird, but when you come ever on an academical conference, study it. You will see there are more open seats in a room than in different conferences. It's very unique. And of course, the further you are in the back row, that's always full loaded. But you should study it. It's not normal. I saw people coming in eating. You won't see that on different conferences. And please go ahead, eat. But it's a very typical thing you see in academical conferences. You don't see it in other conferences. So there is very typical behavior you see. I see more laptop screens than on other conferences. You never see that in a regular conference, which is not an academical environment. So when I study you, I can predict your behavior because it's typical in your environment. It's not about good or bad. It's just behaviors you see. And that makes it nice because it's part of your behavioral codex. And every group has a behavioral codex. That's typical for social animals. Another similarity is, of course, the genetical material. We are not that much different from chimpanzees. That's also why in research, chimpanzees were very favorite study objects in the past, because they are so similar to humans. And what makes a huge similarity is self-recognition. And as I said, to understand human behavior is a very good starting point also to influence behavior. That's what Stephen Covey said. And that is also looking unique because we see this in chimpanzees, bonobos, orangutans, dolphins, elephants, and that's the start of all problems. Because if you can recognize yourself in a mirror, you can lie, you can manipulate. Chimpanzees can stare at you, start to lip smack, they start to groom themselves, and say, come a little bit closer. And then you are just on one arm length. They grab your hands, bite in your fingers, and they tell you who the boss of the group is. And they can lie, they can manipulate. They can holding back information. And these are your colleagues. These are the people you cooperate with. You never can trust them. And some people say, no, we are always honest. No, we are not. Even worse, we don't like honest people. Because if you always would say what you think, it would get very nasty at the work floor. You sometimes see situations where you think, whoa, when I would now express what is on my mind, something would happen. I was just looking at a poster. There was in where the sandwiches was, there was also a poster wall with diversity, inclusivity, and on the left side there were a few comments where you could write down what you would do. And one of the comments I was reading, okay, you are sitting in a meeting and somebody is making a joke that's not appropriate. How would you respond? And most yellow sticky notes I saw were saying, I address it. You're not. Nobody is addressing it. That's the reason why we have a lot of behavioral problems in organizations. Yes, in our mind we want to address it, and we get really furious about what we hear. We get emotional about it, but when it is our boss who made the joke, we're not going to address it. And we just walk outside. We feel awful about our own behavior because we didn't say anything, and we just shut up. And we step into the meeting next time, feel the stress, annoyance, but we just continue. That is how people work. And then you can say, that's bad, that's not good. But the reason we do that, because we live in social groups. And the reason that we do that is we want to be having a good feeling within the group. We won't have arguments in the group. We will want to be nice in the group. We want to have harmony in the group. And that's why we also lie. Sometimes people see people and think you are awful. You are a bully, and I don't say it because I just want to work in harmony. That's a challenge we are dealing with. Another challenge we are dealing with is that when I look to chimpanzees, is they live 24 hours a day in one social environment. So 24 hours they are sitting in one group of 50, 60 individuals. That's not what our human environment looks like. Our human environment looks a little bit like this. And I don't know if you can see it everywhere, but we are part of a private domain. And private domain is our family, friends, hobbies, maybe our sport, but it's a very limited environment, but still different groups. We are part of a public domain. When I'm walking here on the street, I'm part of a public domain. The neighborhood where I live is a public domain. So we are part of a huge public environment with different social groups, and these groups influence me. And that's why when I go into Maastricht on Saturday, this huge herd of individuals, they guide me. I don't want to walk in that direction, but I just follow because it's social pressure. And then you have, of course, a group that we call a professional domain. And a professional domain is extremely complex. And you have colleagues, you have international cooperations we are part of. You are part of an academical group, but also probably of other research groups. Maybe you have to do with patients, research groups. So it's a very complex social structure with different small social groups. And then very interesting is we have nowadays also an online domain. That makes it very interesting because the online domain is very new. And the problem is we don't know exactly how the online domain influences the other domains. For example, private domain, but also professional domain. We don't know that. We have clues about it, but it's a research area that's particularly new. Does this make sense? In this picture, if you have questions, just raise them. But the problem with this is that we don't know how people influence each other. We don't know, because we have a huge time stress nowadays. What we see, for example, is that a lot of people know that we have to check email. I saw what people doing. That's so insane. You are today on a symposium. Take your time, take lunch, groom your colleagues, groom the people you never have seen before, spend time, have fun. But now the stress of all the emails coming in. So we have really time stress. And then WhatsApp and your family is asking you some things, and then the school of your kids is phoning because there is a problem going on. Everything is interconnected by technology. But there is also authority stress. Authority stress is who has the truth. In the past, it was very simple because people who had studied something, people who had experienced, they had the truth. Nowadays, you have the truth when you have a lot of followers. So why would I believe somebody who has a small group of colleagues, studied a few years something, did research on a topic, but has no followers? When I have to choose, and I have to choose between somebody who studied an area of science for 20, 30 years, or somebody who has 1 million followers. It's evident who I believe, 1 million followers. Don't worry, I don't do that. But it is how our CARIM behavior is changing. But you still have a choice. Yeah, you don't follow the herd, but there is always a challenge in it. Because in our brain, there is something very small. And saying, imagine that the other 1 million are going into the right direction. So stepping out of the herd, it's a much bigger challenge than stepping into the herd. And I make very small steps. A very small example. I'm in social media, but I'm absolutely not a person who believes everything on social media. When I want to have advice, I go to a professional. But I had been in South Africa last December, and I came back. And I had something here on my leg, a black spot. Oh, nasty. So what do I do nowadays? I make a photo, and I ask Dr. Google what my problem is. Oh yeah, African tick fever. I had seen it before, so I sent my doctor just a very short notice, please, I need antibiotics. Because Dr. Google says I have African tick fever. And then she writes back or says back, no, I want to see it. Please, can you send me your photograph? And then she comes back and says, yeah, you need antibiotics. So I respond, you see, Dr. Google was right. And so in a very small step, I think a lot of us would do that in that way. It's a very normal process nowadays. But that includes also that we change slowly our believing. What do we trust? Where do we believe? Where is the truth? It's changing very slow. Which direction is good or bad? I don't know. But it has influence on how we make decisions. Other questions about that? Yeah. Yeah. The question I repeat also for upstairs is that when we look at it, it's maybe not just the process that somebody who had been also in the past very charismatic would have had followers, and now it's just a new medium that is making use out of it. That's the summarize of your question, I think. That's right? Yeah. And no, you're absolutely right. So I think technology, so the online domain is changing. And maybe the basic principles in our basic brain are still the simple ones and still the same mechanisms. So we look, where is the herd going? Okay, that's the direction I want to go, because probably most of the people running there are the right ones. The only issue is that in the past we understood very well how it worked because it was studied very long, and now we see a few mechanisms that are completely new. But in the basic, you're right. Our primal brain is just saying, oh, there is the herd running, that's the direction I want to go. And if that herd is just a physical group of people I see going, or it's an online world, that doesn't matter. It's still the same primal behavior. But the problem is that in that new mechanisms, people can use different ways of influencing. Yeah, but it's a very interesting part. And the other thing is what we see is that when we look to groups, for example, in a professional domain, but also in a public domain, is that we see a bigger diversity. So what is changing is that where I, maybe 10, 20 years ago, I would see not much diversity in a group, and then I mean not how people look like, but in the behaviors they show, I see now an increasing diversity in behavioral patterns. And maybe I should explain it. So sometimes I come in a group, and I think this is a typical gorilla group. This is Jambo, 200 kilograms. He is a single male in a group. The other adults are females, around 80 kilograms. And in the morning he says, I'm the boss of the group. And every individual in the group says, yes, you are the boss. No discussion about it. Sometimes you have a woman that stands up, then she is beaten up, so she immediately understands now he's still the boss. If there is a question, where are we going to look for food? All the individuals look to the big boss, and they'll look, where are we going to find food today? And he is not a typical leader who says, okay, but you're the professional, what are your thoughts, what are your needs? He just says, to the left. Sometimes you have teenagers who walk to the right, that teenager doesn't walk anymore tomorrow. If you have a conflict, two females are arguing, he shows up, beats them up both, conflict done. It's a very, very simple structure. And believe me, a lot of people always ask me, where can I hire him? Because there is no stress, there are no arguments, it's evident. We know where we go. Problem is, if he doesn't have the answer to the question that's raised, nobody else will stand up and say, oh, I have also no idea, because that's not allowed. And then we come to a chimpanzee society. In chimpanzees, you see different behaviors, as many males as females in the group. Males are always building political coalitions to become the leader of the group. So you always need support from other males to become the leader. And when you have that support, the ones who are supporting you always start to beg for rewards. And that's most of the time food. When the rewarding stops, the support will stop. So somebody else will become the new leader in the group. If you are working in an environment where you had a meeting and you made a few decisions in that meeting and you say, okay, that's done deal, we made a decision on it, but next week you're again in a meeting and everybody starts to discuss looking like there hasn't been a decision last time. If you have that feeling, sometimes you are working in a chimpanzee group. So everything can change every day over and over again. You're never sure what the situation is. Decisions made, next week it can be different. And interesting in chimpanzees, it's a very political organization. And you have alpha females. Sometimes people ask me, is there sexual harassment in chimpanzee groups? No. Because you can try it twice, but the third time you are castrated. Because alpha females don't accept negative behavior. They want just to have peace. And of course they can be aggressive and etc. But there is always a way of, look, you can go somewhere, but there needs to be a moderate way. And we have bonobos. In bonobos, the females are the bosses. In the morning, they beat up the males, so the males know that they are the lowest ranking individuals in the group. Females build coalitions. This is the management team in Apenhill Primate Park. 3 women, Jill, Lubosa, Lometa, and they cooperate. And they have what we call a fission-fusion structure. So groups meet, there is a merging process, fusion. After a while, they split, fission. They look out for new individuals, new fusion process. And what we see in all these groups is that by this behavior, the advantage of it is that they have much more flexibility, but they need to have very strong rituals to have this bonding process. You need to understand who is the other one, what is your position, what is your role. And then we have orangutans. And orangutans, they are the smartest primates we know. They are much more solitary as the others, but they live in small social groups. So they are part of a small social group. But they also prefer sometimes to work remote. Right? They love to sit in their own environment. They not always sit in the middle of the group. So sometimes they are just walking around in the forest in their own area alone because they do not need to be always in a central position. The reason I show you these 4 apes, and I could add more behavioral patterns to it from different species. But the challenge nowadays is, and specific also in your environment, is that you will meet all these different types of behaviors. You will meet the diversity of behavioral groups. And that is really challenging. The question is also, what behavior would fit the best in your environment in 10 or 20 years? Are we heading to that? And when I look from my position, I don't know if I can make this statement, but when I look, just hands up, I ask you, who is over 50? Yeah, that's interesting. How few women raise their hand. Yeah. Who is under 30? Under 30. Yeah. You see a complete mixed group. Even a slight, little bit more women than men in the group. So what does this conference look like in 10 or 20 years? It will be different. How does it look in behavior? It will be different. And that is really also the thing about how is this going to change? And what is the influence on behavior? How processes work? That's interesting. And then when I come to the topic, the central topic I want to discuss, Ingrid, I look for you for time management. I'm very bad in time management, I say. So when you start to get nervous, I respond. So if the world is changing, and I don't think it is necessary to discuss that, the world is changing. That's why I raised that question, who is over 50, who is under 30. Look to the diversity in the group. Think about what it will look like in the future. What is the influence on the online world? How can you access data? How can you access information in the world? It's changing. And that includes also that we will have a larger need for cooperation in the future, because this diversity that we are heading to includes also that we need more different knowledge. And that's not a gorilla behavior style where we say, I have all the knowledge. No, the knowledge is in the world. So we need absolutely to head to cooperation. And if you talk cooperation, in many organizations, that's one of the main topics. And I think also in your environment, cooperation is key. But we have two ways of cooperation. One way of cooperation we call coexistence in biology, and the other way we call cooperation. So what is the difference? I go back to the savannah. This is a giraffe. And the advantage of a giraffe, his long neck, he is overlooking the savannah. And if giraffes are resting, they always look in a different direction. They are not heading to the same direction, always a different direction. And the advantage of that, if you're a gnu or a wildebeest or a zebra, you always stand very close to giraffes. Because when a giraffe starts to run, you also start to run. You do not start a work group to discuss and to research why giraffes are running. No, you start to run. Because they have seen something. So you use the advantage of a giraffe with its long neck. You make use out of it. However, if a giraffe has missed the lion that's coming closer, you have the advantage of the zebra. If zebras are standing very close to each other, you won't see where the head or the tail is. You can't see it. You can't distinguish. It's just one huge animal. So lions avoid a herd of zebras because you don't know where to attack it. It's just a huge striping pattern. So that's the second advantage. And then the third advantage is the wildebeest, because they have these sharp horns, so they can attack smaller predators. So this is what we call coexistence. Everybody brings in a part of competence, and you make use of that. And that gives you a better chance to survive on the savannah. You make use out of it. But the problem is, when you go out to look there, in 10 or 20 or 30 years, they still do exactly the same. There is no evolution in it, or very slow evolution in it. There will be evolution, but it's very slow. If you look to different behaviors, and then I come back to the research of Professor Köhler, he said, that's what he also studied. He studied coexistence, making use out of these competences. But could there also be an opportunity that we see that individuals cooperate in a different way in a challenge they never met? And he defined a very simple experiment. And the experiment is what we call the Köhler shelf. And the Köhler shelf is just a shelf on wheels. There is food on it. Normally it's aligned on the yellow line here. To get access to the food, two chimpanzees need to cooperate, they need to pull a rope. And when you see the first time, so this is the first time we showed the chimpanzees this experiment. The first chimpanzee enters, that's Sonia. She pulls the rope, sees no rope is slipping through ice, and she walks outside to find another colleague. And she brings in another colleague, that's Caroline. And it's very specific, Caroline, but I will explain that. So she brings in the second colleague. And then within a few moments, they get access to the food. This is what we call cooperation. So you have a new challenge. And what is key in this? Professor Köhler said, it's not the key of offering help, but the key is asking for help. So the key element is here that Sonia goes out there and says, please come in and can you help me? Not in words, but in signatures, language, body language. And so we said, okay, but if this is so key element, and Francois, for example, he did this with elephants, they understand it. They did try it also with dogs. Dogs don't understand it. If you try it with wolves, they understand it. So you have immediately also a political discussion about wolves, but they understand what cooperation is. So we thought, if this is so simple, can't we change the experiment? So can we not manipulate it? So what we started to do is we started to reward the two chimpanzees in a different way. So the left chimpanzee got now 3 grapes on the shelves, where the chimpanzee on the right just got 1 grape. And grapes is a very important food for chimpanzees because there's a lot of sugar in it. And now we are going to reward the left chimpanzee, that's Jana, with 4 grapes. Sonia we will reward still with 1 grape. And we are showing very clear what the reward is. Then we throw the rope. And then we see Sonia doesn't cooperate anymore. She refused the grape. It's the best reward you can get, a grape. It's huge. But she says no, probably because her neighbor got 4 grapes. And this is, of course, what we see also in a lot of corporations, is that, okay, I may need to make an investment, but who gets all the rewarding? I found it interesting, on the same posters I was just discussing, there was exactly these questions on it. I write a paper, but somebody wants their name as co-author on it. When do you accept that? There is the exact same mechanism working in there. And so we're thinking, okay, how can we change this for a second time? So what we did, we closed the sliding door. We exchanged Jana, we were sitting on the left, for Caroline. And when Caroline is sitting on the left side, Sonia accepts a reward of 8 grapes, or a difference of 8 grapes. So Sonia is still 1 grape, but at that time, Caroline got 9 grapes. So it makes a difference who is sitting on the left side when she says, okay, this is acceptable. And what is the difference between Jana-Sonia combination or Jana-Caroline combination? Jana and Sonia, they're 2 colleagues. They walk in the morning and they don't see each other. Maybe they say morning, that's everything. But Jana and Caroline are seeing each other and say, hi, shall we have a coffee? Good morning. How was your weekend? What are you going to do next week? And where were you yesterday on the conference? Was it nice? What did you learn? What did you bring home? There is social interest in each other. And they are friends. And then we see that the appreciation of the reward change the moment that you have a different relationship. And chimpanzees are building relationships by grooming. And grooming is just not because there are parasites in the fur, but it's social bonding. Chimpanzees don't have fleas in their fur. They don't have parasites in the fur. But they are showing interest in each other. And they are relaxing. And they're showing trust in each other. And that's where the bonding process starts. And I think in a very quick changing environment, one of the key elements we should start with is spending more time in grooming. I saw today your lunch, you had the poster time to walk around, discuss, meet, and I would say use that time. Because that time is so precious. Because that's the time where your grooming behavior starts. And I hope that today, when you go home, tomorrow back to your regular work, that you say to your colleagues, please, let us have a few hours grooming each other. It doesn't need to be similar as the chimpanzees, because then we get different discussions. But it is at least showing interest in each other. And that brings the opportunity to learn from each other, building relationships, building connections, and also building a future-proof organization. I would say have a very enjoyable grooming time together and a good meeting and good conference today. Thank you.
Thank you, Patrick, for this very interesting and also confronting lecture. There's time for one short question. Is there a question for Patrick?
Thank you very much. Does it work? I have a short question. How do you see the different behaviors in primates related to the different generations that are now in the workspace? So I think we have the boomers, Gen X, millennials, Gen Z will enter or is entering. So how do you, you are. I'm so ignorant. I'm being so ignorant. Maybe even Gen Alpha, but how do you see the relationship here?
Yeah, one key element we sometimes forget about is that what we see in organizations, a much larger spread in age in organizations. So I started to work, 30 30 years ago, even already a little bit longer. But then a lot of people disappeared when they were 60, because that was a normal age to retire. Now we see it's 67, but even luckily people continue longer to work, so we see a huge spread in age. There are a few researchers, and one of them I find very interesting, because he said the issue is not that new generations come into the organizations who have different behaviors, but we don't understand each other. And we don't understand each other's perspectives. And that makes it very complex. So I think what is happening is not very new. But what is happening is that we spend less time with each other to understand what the differences are. When I came to work in an organization, I came with completely different behaviors as my colleagues of 50 plus. Nevertheless, I was sitting together with them. I was seeing them every day, observing them, they were observing me, and there was much more interaction. And I think one of the big challenges nowadays is that we lost that interaction, and that's the reason why we don't understand each other anymore. And I don't think Gen Z is a problem, but I think these boomers and these millenniums, they are the problem, because they don't look to what the opportunity is to learn from each other. And I think one of the best things is learning from each other. Unfortunately, I made last year a photograph in France, and unfortunately I don't have it here, but I make a combination out of it, because I was walking in a botanical garden and I was observing two boys, I think 15, 16 years old, and they were sitting on a table and talking to each other. No phone, no devices, just talking to each other. And I really turned around and I looked at two boomers sitting on a bench doing this. Observe in restaurants, it's more the boomer that is using their device than the Gen Z people. So we need also to be very careful about biases. And of course we look different, but it's important. One short, and then I go back. Never do this during presentations. People always tell me never go backward, forward. But one thing in this picture is, when I look to the generation of my parents, authority was in a public domain. What my neighbor said, what the pastor said, what the doctor said, they were people with authority in a small village not far from here. My generation grew up, 50 plus, where people who had achieved something, they had authority. That was normal. Now we see a generation that says, no, authority is here. And I don't say it's black, white like that, but there is much more competition and understanding what authority is. And when I go, for example, here in Maastricht to the hospital, I immediately see the challenge that a lot of people lose their status. Because young generations walk in and are saying, okay, what can you do for me? No. This is what I want you to do. And that's a different thinking. It's not a wrong thinking, but it's just a different thinking. And our biggest problem is we don't meet. We do not learn from each other. And to be very honest, when I walk around here, I see clusters of ages. And this is an opportunity to say, well, I'm 50-year-old, was 25, I want to talk with you. Because I want to learn how you think. We don't do that. Or when I'm 25, just working on my PhD, I see somebody, 50 plus, 60 plus, and say, whoa, wait one sec, come here. I want to understand how you think, how you make your decisions. And that's really a challenge that we need to learn from each other, and it's really not a big challenge, but that is how the world changed. So you had a very short question, but sorry for the long answer.
No problem, but join me in thanking Patrick again.
Thank you.
And then I hand over to Joost Lumens, who will take over the next session.
Thank you very much. Very inspiring lecture. Cooperation. We have a great session now with Dekker laureates, and we all know how important Dekkers can be. we also, many of us know how painful it can be to get there. But I really would like to ask you, and certainly the younger scientists, let you inspire by Elisa and Job, who are going to share some of their work that led to those grants, but also their plans. And we'll start with Elisa D'Alessandro from the Department of Physiology, and she's going to tell us about the interaction between fat and fibrosis in the context of AF. So be inspired. And about collaboration, they will all, both of them, they will tell you how important it has been to be with the Research Council. You told me personally, so maybe you can share that with the audience, because it's super important that you all reach out to the Research Council if you have ideas in the earliest phase possible. Elisa.
So it's a great pleasure to be here today and celebrate this CARIM Day with you. It's also a great honor for me to share with you my project proposal. So for those who don't know me yet, I would like to say a few things about myself. As you can probably tell from my accent and guess from this picture up here, I'm Italian. However, when I was 25, back in 2017, I moved to Maastricht to start my PhD at CARIM. And I thought it would be good for me to live somewhere quieter and calmer than Italy. Little did I know that Maastricht would feel much more like at home than I expected. And so I settled in rather quickly, and I even convinced my dad to celebrate King's Day with me. So I can really say that I can call Maastricht my home right now. But jokes aside, I came to Maastricht and to CARIM to participate in something very important. I was investigating the molecular causes underlying atrial fibrillation. Now, atrial fibrillation is the most common cardiac arrhythmia in clinical practice, and it is characterized by chaotic conduction of electrical impulses through the atria. Every 12 minutes, someone in the Netherlands develops atrial fibrillation, and every 39 minutes, someone suffers a stroke because of it. So AF is a real healthcare emergency. So as I just mentioned, AF increases the risk of stroke by 5-fold, and this is a very complex and multifactorial process. In fact, this includes abnormal blood stasis within the atrial cavity, endothelial damage or dysfunction, and also an abnormal activation of the coagulation system, also known as hypercoagulability. So together, these three processes really work together to contribute to the formation of thrombus within the atrial cavity and to stroke. Importantly, we found in a procoagulant mouse model that hypercoagulability can also enhance AF inducibility and stability, and it is accompanied by increased fibrotic tissue within the atrial myocardium. Moreover, we found that activated coagulation factors such as factor Xa and thrombin can trigger cardiac fibroblast fibrotic responses via the activation of a specific family of cellular receptors, the PAR receptors. And these mechanisms can contribute to atrial structural remodeling and potentially also promote AF progression. So together, these observations also suggest that the relationship between AF and stroke may also be bidirectional, and that hypercoagulability can contribute to the AF-related structural remodeling that we observe in the atrial myocardium. So during my PhD at CARIM, I had the great opportunity to collaborate with two exceptional CARIM divisions, the heart and the blood divisions. So through this collaboration, I could further investigate the role of the coagulation system and PAR receptor signaling in atrial fibrillation using the GOAT model of AF. We hypothesized that direct inhibition of the coagulation factor Xa and thrombin via the oral anticoagulant rivaroxaban could attenuate atrial structural remodeling in AF, possibly via the inhibition of the PAR receptor signaling within the atrial myocardium. We found that while goats with atrial fibrillation showed a significant increase in atrial myocyte size, goats with atrial fibrillation treated with rivaroxaban were protected from this hypertrophic response. Using human iPSC atrial-like cardiomyocytes, we confirmed that thrombin was involved in hypertrophic response and that thrombin via PAR1 activation was indeed able to upregulate hypertrophic markers. So this data further strengthen the bidirectional crosstalk between atrial fibrillation and the coagulation system, and also highlight PARs as important cellular players in the remodeling that happens within the atrial myocardium in AF. So let me tell you something more about the PAR receptor family. So this family includes 4 different isoforms, which are differentially expressed on a variety of cell types, where they mediate physiological and pathophysiological responses. So one interesting characteristic of the PAR receptors is that they become activated upon cleavage of their N-terminus domain by different proteases, such as coagulation factors. However, the coagulation factors are not the only PAR activators. In fact, other proteases can activate PARs. An example are the matrix metalloproteases, the MMPs. Now, I guess many of you know that the MMPs are involved in inflammatory and fibrotic responses, but they also upregulated within the atrial myocardium in patients with AF. And this is also very important because it suggests that even in the presence of oral anticoagulants, the PAR receptor signaling within the atrial myocardium may still be active. And this means that it can potentially support structural remodeling and promote AF. Moreover, the PAR receptor pathway is not the only pathway, signaling pathway involved in the complex and very often multifactorial AF pathophysiology. As you can see from this image, there are many different signaling pathways involved in the structural remodeling that happens during AF. And obviously, this makes it difficult to identify effective strategies to really slow down atrial fibrillation. So this brings me actually to the healthcare problem that I would like to address in this Dekker project. In fact, what strikes me about atrial fibrillation is that AF remains a progressive disease. And despite we are gaining knowledge about the underlying mechanisms and we are even able to keep some patients in normal rhythm, we still don't know how to keep the atria free from the atrial disease or atrial cardiomyopathy underlying atrial fibrillation. So what we really would like to know is how can we keep the atria healthy? So in fact, one of the key features of this atrial disease underlying AF is this highly heterogeneous epiendocardial gradient of fibrosis, which provokes electrical disturbances and further makes atrial fibrillation more complex and difficult to treat. In this context, the epicardial adipose tissue infiltrates the atrial subepicardium, colocalizes with inflammatory cells, and further promotes fibrosis, also increasing the likelihood of AF episodes. Despite this knowledge, we are still lack of important information to really understand the atrial cardiomyopathy underlying AF. For instance, we need to know what specific cell types are involved in the remodeling of the atrial myocardium, how they interact and talk with each other, and most importantly, where this spatially heterogeneous remodeling process begins. So we propose a more comprehensive approach to the study of atrial fibrillation by looking at the crosstalk between the epicardial adipose tissue and the atrial myocardium within its spatial context. So for that, we need advanced spatial techniques, which I will tell you in a moment. So normally, the epicardial adipose tissue protects the myocardium from different threats. My pilot gene expression data on the epicardial adipose tissue of goats with atrial fibrillation suggest that even in the presence of AF alone, the epicardial adipose tissue may maintain a protective anti-inflammatory phenotype. However, in the presence of other inflammatory states, such as advanced age, the AT, the epicardial adipose tissue, may become inflamed. And this may trigger a vicious cycle where increased inflammation can further promote atrial fibrosis, and fibrosis can exacerbate atrial inflammation. Now, my pilot in vitro data suggests that the PAR receptor signaling may play an important role in this vicious cycle, and that modulation or inhibition of the PAR receptors has the potential to restore the original balance in this crosstalk. So in this study, we will first use spatial transcriptomics to address the spatial heterogeneity of the structural remodeling NAF. So we will use atrial tissue samples from patients with and without atrial fibrillation to create a single cell resolution map of the crosstalk between the epicardial fat and the atrial myocardium. Now, this map will help us to understand what specific cell types are involved in the remodeling process, how they interact with each other, and how this interaction changes with age, and where they preferentially localize. This analysis will be done in close collaboration with Professor Kramann at Aachen University. Professor Kramann is one of the world-leading experts in kidney and cardiac fibrosis and has gained a lot of knowledge regarding the fibrotic processes in these organs using spatial transcriptomics. Next, we will also assess how the impact of AF and advanced age and their combination affect the epicardial adipose tissue phenotype and properties. For that, we will use the goal model of AF, and this model will allow us to really map the effect of AF and age on different EAT depots around the myocardium. And finally, I will further investigate the crosstalk between the epicardial fat and the atrial myocardium using in vitro and in vivo models. So I will specifically study whether modulation of the power signaling in this context can protect the atrial myocardium against remodeling processes. So despite my Dekker project has just started, I really would like to show you some of the activities that me and others have already initiated. A great achievement is this implemented protocol that allows the collection of atrial and epicardial adipose tissue samples from patients undergoing cardiac surgery. So this improved protocol relies on a strong communication and collaboration between us and the cardiac thoracic surgeon working in the OR. Through this great team effort, we were already able to collect from the same patient samples that we will use for spatial transcriptomics, but we will also able to create the epicardial adipose tissue secretome and isolate primary cardiac fibroblasts and adipose-derived stem cells for functional analysis. So I do believe that together we not only ensure patient care, but also we can optimize the use of these very precious samples. So to conclude my presentation, I would like to show you some very preliminary data that I've collected so far. As I said, we can use the epicardial adipose tissue to create the epicardial secretome, so a secretome that contains all the paracrine factors released from the epicardial fat. In these experiments, I used the EAT secretome from AF patients to stimulate human cardiac fibroblasts. What I found was that the epicardial adipose tissue secretome really triggers an inflammatory and fibrotic response in these cells, as you can see for the upregulation of IL-6, CCL2, also known as monocyte chematractin protein 1, but also the upregulation of some fibrotic genes like osteopontin 1 and the connective tissue growth factor. What I also observed is that by selectively inhibiting PAR1, PAR1 inhibition could actually protect the cardiac fibroblasts from the pro-inflammatory and fibrotic signaling induced by the secretome of the epicardial adipose tissue, suggesting that the EAT may secrete factors, coagulation factors or MMPs, able to trigger the PAR receptor signaling within on cardiac fibroblasts in this case, and potentially also on the myocardium. So, to summarize, what do we know about the PAR receptor signaling in the context of AF? Well, we know that activated coagulation factors can trigger PAR receptor signaling on atrial cardiomyocytes, and this can support hypertrophic growth. But we also know the PAR receptor signaling on cardiac fibroblasts can promote increased fibrotic and inflammatory responses. On the other hand, the epicardial adipose tissue in AF is known to secrete inflammatory molecules which can further exacerbate atrial inflammatory processes within the atrial myocardium. But it's also known to secrete fibrotic molecules which, as my pilot data suggests, may have the potential to further support the pulse signaling within the atrial myocardium. And finally, something that I couldn't show you for the sake of time, but that I would like to mention, is that my pilot data also indicate that the PAR receptors are expressed also in the epicardial adipose tissue. Now, there are some studies that indicate that PAR signaling on subcutaneous adipocytes support inflammatory and fibrotic gene expression. So we can, this may suggest that PAR receptor signaling in the epicardial adipose tissue may do the same, further promoting inflammatory and fibrotic molecule secretion, but also suggests that the proteases secreted from the fibrillating atria during atrial fibrillation also activate the PAR receptors on the epicardial adipose tissue. So in conclusion, these observations indicate that PAR receptor signaling may be very important, especially in the context of a crosstalk between the epicardial adipose tissue and the atrial myocardium, but also show that further research is really needed to fully understand whether modulation of PARs in this context can protect the atrium against the atrial disease underlying atrial fibrillation. So with this, I would like to thank all the people that collaborate with me, the CARIM Research Council, of course, because it was crucial, especially in the final part, in the preparation of my talk. And I would like to thank you for your attention.
Grazie, Elisa. Any questions from the audience?
Thank you very much, and congratulations on the grant on this great study. Single nuclear RNA-seq studies from whole heart regions that include also atria are showing that there are multiple subtypes of adipocytes. So sometimes there's 4, sometimes there's 8, and it differs per studies. So I'd like to ask you for brainstorm a little. What is the evidence for what you were saying that the adipocytes from the epicardial tissue will eventually infiltrate epicardially in atria, and similar situation is also in the ventricles. So what do you think about it? Is it exactly the same adipocytes that follow maybe the coronary artery path, or is the origin a little bit different? And how could that different possibility influence the way how you analyze your spatial data?
Thank you very much for this question. This is really interesting, and I really would like to have a very straightforward answer. I do not have that one yet, but there are a couple of interesting theories that I would like to explore. One of these is the activation of the epicardial layer and progenitor epicardial cells, or even some stem cells present in the epicardial adipose tissue. So there are a couple of studies, experimental studies, that show that during atrial fibrillation there can be a reactivation of the epicardium, and some of these cells can differentiate into fibroblasts, or depending on the stimuli, on adipocytes. That can be a possible explanation. Another explanation is, proliferation, or also like an intermediate type of adipocytes, and then eventually infiltration. I think, we need some very dedicated spatial single nuclei, of course, we need that, but also spatial data about that to really understand cell identity and fate eventually.
Yeah, I would say that your spatial analysis will give you better responses than the single nuclear one, but indeed, this is what you're going to test, so good luck.
Thank you.
Thanks, great presentation. So you hinted on age, but what else determines the amount of epicardial adipose tissue? Is it like lifestyle, BMI, or ambient temperature? Do you know?
Yes, it has been observed that cardiometabolic diseases play a very important role in there. So diabetes, obesity, not so much BMI. I think there are some studies that show that in AF especially, there is an increase in EAT volume even independent of BMI, and age as well.
Age, yeah. Is it always bad?
Sorry?
Is it always bad?
Depends how you get there, I think. And there is healthy aging, predisposes to yeah, maladaptation, I think, and then the injuries that you get with comorbidities. In that case, it really depends.
Thanks.
Okay. I think in the interest of time, we have to move on because we're behind on schedule. It's not your fault, Elisa. So thank you very much. Then we move on to Job Stocks, who many of us also know already for quite a while. He's a clinical technologist, and he's going to talk about SCAR and eventually arrhythmia, but especially the time in between, as I understood. So Job, please, the floor is yours.
Correct, yes. Thank you very much. Good afternoon. Thank you very much for having me here. My name is Job Stocks. I'm a clinical technologist and also a postdoc here at CARIM. And I will present my upcoming project, Dynamic VT, which was recently granted by the Dutch Heart Foundation, in which I plan or aim to fundamentally change the way we look at risk of sudden cardiac arrest, from static to dynamic. So to start with, we know that myocardial infarction increases the risk of sudden cardiac arrest, which is caused by ventricular tachyarrhythmias, VT or VF. We know that ICDs, implantable cardioverter defibrillators, can directly treat sudden cardiac arrest or the arrhythmia once it occurs. It does so by carefully monitoring the heart rhythm, and once things go bad, it will give an electrical shock or impulses to restore the normal heart rhythm. And this is a very effective form of therapy. However, the current problem is we are very poor at predicting when the ICD is needed, with the emphasis on when. And the consequence of this is that it often takes many, many years. In this graph, it's only 42 months, but in practice, it's even much longer. Can be 8, 10, 12 years until the ICD first delivers its therapy, which means that, well, often we implant them way too early. And this too early implantation of ICDs comes with, well, complications, bleedings, infections, inappropriate shocks, which can be very painful, but also cause anxiety for the patient. Also, this comes with a high burden for clinical care and for society. Taken all together, all of the ICDs in the Netherlands, they take 150 million euros a year. So imagine that we can postpone this procedure for many years, or maybe even make them unnecessary altogether. So this led to my conclusion. I think we can do better, and I think that the right therapy should be given at the right time. I think the underlying problem is that we have a fundamental knowledge gap in the dynamic risk for sudden cardiac arrest, or ventricular tachyarrhythmias. On the left-hand side of this graph, we know into very high detail what happens there just after myocardial infarction, even to the microscopic level. We also know what goes wrong many years later, once sudden cardiac arrest occurs, but this period in between that remains largely unstudied. So if we plot the risk of sudden cardiac arrest over time, of course, in orange here, there's a threshold that needs to be reached in order to get sudden cardiac arrest. And this is I'm going to simplify things a little, but this is the current clinical paradigm. So shortly after myocardial infarction, 1 or sometimes 2 echocardiograms are made to assess left ventricular mechanical pumping function, of which we know that is a poor predictor of long-term arrhythmias anyway, because it says little about the underlying electrical problem. But anyway, 1 or 2 ICDs, because echocardiograms, because it's the best that we have right now, and based on that, decision is being made, ICD implantation or not. And after that, there's no active monitoring anymore of the dynamic risk. Well, in real life, we know that this risk can fluctuate over time. It can increase over time. There's many things happening there. So that's exactly what I'm proposing on what I'm going to study in dynamic VT. Firstly, I'm going to apply deep phenotyping of 3D cardiac electrics and also structure to better understand what's going on. And secondly, I'm going to try and come up with dynamic risk profiles, more of a statistical approach. And hopefully, in many years, we can postpone this decision by many years as well. For this project, I will use my clinical technological expertise. So firstly, non-invasive electrocardiographic imaging, or ECGI, which is a technique that I have a lot of experience with. What we do is basically we combine a lot of electrical signals measured at the body surface with a medical scan, CT or MRI, and combining both enables us to look at 3D cardiac electrical patterns from the outside in, non-invasively. Secondly, I will use my expertise in imaging and integration by using CT and MRI scan analyses, constructing 3D models of them, of cardiac structure, and then integrating those with the ECGI as well. And thirdly, electrocardiograms, ECGs, and artificial intelligence as well, to come up with predictive models on larger populations. So in the first work package, the first part, I will do deep phenotyping of the natural progression after a myocardial infarction. This means that, again, if we take a look at this graph, which shows the risk of sudden cardiac arrest over time, I will do repeated recordings in high-risk patients, which means twice ECGI and CT. So these will be 30 patients times 2 recordings. And I will compare the outcomes of this to other cohorts that I already have available or will be available soon. Healthy subjects, low-risk patients, and patients who already had sudden cardiac arrest. I already gathered some pilot data for this work package as well. I do have to note that it's a bit of a different population. These pilot data is from people who have survived unexplained sudden cardiac arrest, so not after myocardial infarction, but still the result, of course, remains the same, which is an electrical problem and sudden cardiac arrest. And we looked into heterogeneity of repolarization with ECGI here. And what you can clearly see is that the people on the left-hand side of the graph show more dangerous patterns, increased heterogeneity of repolarization, as opposed to those remote from their event. Secondly, the dynamic risk profile. I will map long-term changes in the electrical heart behavior by means of ECG, Holter analysis, which is 24 to 72 hour ECGs, and thirdly, ICD readouts. I will do so in patients who had myocardial infarction first, and many years later, sudden cardiac arrest. I have multiple data sets available for this. And also from the same patient group, I have some pilot data as well, and what you can clearly see here as well, even more significant, is that the people who are closer to their event have shorter coupled premature heartbeats, which also impose a more dangerous situation than those remote from sudden cardiac arrest. And this again shows, even though it is different disease etiology, the risk is not static, it's dynamic. And in the third work package, I aim to combine the strengths of the first 2 work packages by studying how the deep phenotyping corresponds to or correlates with the risk markers of the ECG. I will be able to better identify the underlying mechanisms, what's going down beneath, and their progression. So this will provide valuable insights for targeted prevention and treatment. And my vision is that uncovering this green zone here, what is now largely unknown, can hopefully lead to a paradigm shift where we would move from the current static clinical method to a more personalized, mechanistically grounded, and also dynamic way of assessing sudden cardiac arrest risk. If we better know how this risk evolves over time, we can ultimately, identify high-risk periods when needed, and treat them more accurately and effectively. Of course, this comes with quite some forms of potential impact. Firstly, for the patient, right therapy at the right moment without all the unnecessary complications that go in front. Physician, less burden for clinical care. For society, there's lower healthcare costs. Science, new insights and methodologies. And there's also future potential. Perhaps we could expand this to other diseases within or also outside of cardiology. This is my planning, in which you can see I also pay special attention to public outreach. The reviewer feedbacks were mostly positive. Well, I hope so, otherwise I wouldn't be standing here, of course. They appraised the feasibility and the team expertise. But of course, I'm also willing to listen to their advice about taking into account MRI scans and the autonomic nervous system. Well, this is the part where I'm supposed to brag about myself, which I'm not typically very good at, but at least I like to think that my expertise, the embedding, the network, my outreach activities and prior grants have helped me obtain this grant, which I'm very thankful for, as well as everyone who helped me obtain this, either by past work, supervisors, colleagues, and the CARIM Research Council as well, as you was mentioned. And in doing so, I hope to become a more independent researcher and reach real clinical impact. Thank you very much.
Thank you very much, Job. So questions? Yes.
Great, thank you so much and congratulations. For the deep profiling and also for the dynamic profiling, you do longitudinal experiments, right? But you have like, the timeline was 2 years maybe, so how good can you approximate the exact time point then in the end when having 2 years as a like endpoint?
Yes, thank you. Very good point. There's also one of the points addressed by the reviewers. I agree with you. Well, there's 2 parts, let's say, right? There's a prospective part, which I'm aiming to prospectively do the deep phenotyping. And there's a retrospective part in which I use retrospective data already available. In the retrospective part, I actually already have the full length from myocardial infarction to sudden cardiac arrest later on. So in the retrospective part, I think the entire spectrum is covered by means of clinical data. But for the prospective part, I think you're very much right. I only have 2 years to do these recordings, and often it takes 10 years to develop VT, VF, sudden cardiac arrest. I plan to mitigate this by selecting patients at different points in time after myocardial infarction. So a couple of them will be 1 year post-MI, a couple of them will be 5 years, 10 years, and maybe 12 years. So hopefully I can draw the line in between the patients. And secondly, there's work package 3. So what I plan to do in the retrospective part is identify high-risk parameters. I don't know if you're familiar with an ECG, but let's say it's the T-wave width that's really important, or the widening of the T-wave over time. Let's say that's the outcome of the retrospective part. What I would be doing is select those from the prospective study with the broadest T-waves and see what happens underneath there. So in that way, I still hope to be able to extrapolate a little bit. I agree it's not perfect, but I only have 2 years, and I do think we need to start looking into this. I think that's the most important part.
Yeah, thank you, Job. As somebody who experienced several of those shocks, and that's a feeling you will never forget, so I truly hope that this great research will have the outcome you desire. And I will fully support you on the scientific and on an outreach level, so please let me help you out there as well. Having that said, question for a familiar topic for you, but not for me, the ECGI. What kind of additional data does would it provide you for instead of regular ECGs or echoes?
Yeah. First, thank you very much for the proposition. ECGI, it's a technique in which we have, first of all, more electrodes, right? A general ECG has 10 electrodes and we have 250, so I think already by default that should provide you with more information. But the key part is actually that we also make a clinical scan, typically CT, but you can also do MRI. So by using this electrical information that's surrounding the body, and by using a mathematical model, we can reconstruct the electrical activity onto the heart. So that's really the important part. The spatial component, that's kind of the new thing. Because for ECGs, you can very broadly say, oh, it's on the left-hand side or inferior, but ECGI really has better localization of both activation and also repolarization in that case.
Thank you.
Okay, thank you. And for that last question, I recommend you also to look at Jekyll's Yacht, where Job and Matthijs and Jessim were very nicely showing and representing Maastricht as the state-of-the-art ECG researchers. Job, thank you. I think we don't have any more questions. We have to go to the coffee break. Tilman, we're a bit later. We just reconvene at 4, I think, isn't it? Cool. Okay. Thank you, Job, once again.
Yeah. Okay. The last ones are getting in. Please take your seats, and then we can start. It's my great pleasure and honor, even, to introduce to you Professor Henk Markwering from Amsterdam. Henk has been has an impressive career, what I read. He started studying theoretical seismology. Who knows about seismology here? A few people do. Okay, but then you went on a complete different path. And you first went to the Princeton University. Quite renowned university. Later, of course, you was promoted to the University of Amsterdam. In between, you worked for some companies. Yeah. But then finally, in Amsterdam, you embarked on the story of Mr. Clean in the radiology department. That's why I got to know Henk. And he worked on image analysis using artificial intelligence. And he was quite inspiring for a lot of us, and especially for the younger ones. He was an out-of-the-box thinker. The fact that he was so inspiring is also seen in the fact that he has more than 60 PhDs already delivered, as I read. And it's quite an achievement. But he has a big group, and still you have a lot of PhDs under your wings. But he's not only a researcher, he's also an innovator, bringing his research, his thoughts to the clinic and to the market even. You brought some startups like Nicolab, Insteps, Trianect, all to the market. Some are doing quite well at the moment. So yes, also an innovator. But your career is not the most important thing why we asked you here. I think you're one of the, well, for me, best speakers about artificial intelligence. Clear, positive in these times where you hear most negative stories, warnings, the risks of artificial intelligence. This positive message is sometimes nice to hear. You can hear it in podcasts, radio performances, even on television. The thing with radio and with podcasts is that then you miss this broad smile and a twinkle in his eyes when he talks about his work. And that, my friends, here you can enjoy now, live. So, at the end, by the way, this is the Reneman lecture. Usually no discussions or time for questions, but Henk likes to discuss his things. So if you have interesting, exciting questions, please, you can ask one or two at the end, depending on the time, and you are quite happy to discuss them. So all ears and eyes now are on you.
Thank you so much, Wim. It is true, I have a big smile on my face, mostly because I'm really honored to be invited for the Reneman lectures. And also to join this group already for this day. It is really impressive what CARIM already brought together. In Amsterdam UMC, we also are working on research institutes on cardiovascular, but we're way behind to everything that you have been doing here. So it's really impressive, inspiring, and I even heard some gossip about what's going on here. So that's really nice that you're so open about everything, what's happening here. So thanks a lot. So I have to declare something. So indeed, I am a co-founder of 3 startups. So if I'm really positive about something, be suspicious about this. It could be that I'm trying to sell stuff. And I also should mention now that I am a member of the Amsterdam UMC Valorization Board. I know that a lot of people are quite negative about when they hear people about valorization as a new task. So also this could be because of my new task. And nowadays I should also mention that really all the text that you will see and hear is from me and not from a large language model. So usually when I'm asked to present, I try to challenge myself a little bit and to come up with a title. And this was in the summer, and I thought, well, this was a nice title. And then when I start preparing a talk, then I often am confronted with myself, what did I put myself in this time? But I must admit, this time I was not too unhappy with my own choice, because it is, I will be discussing some recent developments, some new parts of doing research. So it includes AI. I cannot call it new, but still it is part of our current research. Impact, we hear a lot of impact also today. We heard already some talks about having impact. Valorization has become the third main task of most universities. And also we have a valorization board. Many people hate this. They think, really, why the valorization? And well, I can imagine this, but still. Also, the long road in this title, this is a long process. If you really want to change something in clinical practice, it takes a long time, long time, so the long road. And also, in English there's a saying, shared troubles is half the troubles. Maybe I can share some with you and you can take some of my troubles away and we'll see what happens there. Okay, and this was a little bit too overambitious. I said, delivering the promise in cardiovascular health. Knowing what you are working on, this is way too much for me. So I will be focusing on stroke today. And if we have some time, I will also talk a little bit about hopefully the next hype that will pop up, the digital twins. I know some people are already looking at me. No, don't start talking about digital twins. Yeah, it is kind of interesting for sure. So I will start talking also about basics, not to insult you. That was not why I'm here and asked to come, but also to make sure that we are all on the same track and so the same understanding of what we're talking about. So AI. First of all, AI, you get a lot of publicity about AI. You hear it everywhere on the radio, on newspapers, and on the television. And this is just me, so imagine there are more people that have a saying about AI. There's really a lot of talk about that. But if we really dive into this, so we can wonder what AI really is. And I also must admit that about 10 years ago, when the whole hype started about AI, I started looking into what is meant with AI, the artificial intelligence. And so when is intelligence really important? That's really in elementary school. Elementary school, all children or yourself, maybe you can remember, oh, this person is really intelligent. And what can people usually do when they're really intelligent? They can do a lot of math calculations. So my first thought was, well, a calculator, that must be artificial intelligence. Who agrees with my thought that I had at the point? Is a calculator artificial intelligence? Hands, please. No, right? No, one hand. Well, thank you that I was not the only one with that thought. No, in general, a calculator is not considered artificial intelligence. Then I move forward. What if you have some scatter plots? I already saw quite a few scatter plots, and you have a regression line through that. Let's see what happens there. Who thinks that this is artificial intelligence? Please, some hands. Ooh, it's good that I started with the basics. This is artificial intelligence. You have data, you want to extract something from the data, even a regression line, that's AI. If you do this, I know for sure that many of you do it, you can say that you're working on AI. Okay, so yes, and as the last example, also going back to elementary school, math is important, but language is also important. I'm really happy with my spell checker here and our language modeling, because if I make a lot of mistakes when I type the first time, and those little red lines under the words tell me that I did something wrong. Who thinks that this is artificial intelligence? A little bit more. No, sorry to say so. This is not artificial intelligence. And let me explain a little bit why. If you look at math and calculators, those are really based on rules. Those are really clear rules. If you add numbers, if you multiply numbers, you know exactly what it is. If you look at the language is also given by very strict rules. So if you tell a computer these rules you have to follow, and that is that's all rule-based. So that's not considered AI these days, I must add. But if you add a lot of data, if you give a lot of data, and you extract some information out of all that amount of data, and it can be really a regression line in a lot of measurement points, that is considered AI. So it's really, if we talk about AI these days, it's really about data-driven approaches. So apparently, I need a little bit more. Where do I point to for the next slide? Battery is gone. Let's try it this way. Yeah, something is happening. So, so it's good that I start with some basics. Another step is the age of AI. Who knows when this started? There is really a birth date even for AI. And I have some years here. And all of these years are important years for AI. And do some people know which is the birth date of AI? 55. Some other ideas? Yeah. No. Okay. This is going better than my first part. Indeed, 1955. There was a workshop, Dartmouth workshop, on artificial intelligence, and that is considered the birth date of AI. And but also the other dates are quite interesting. So in 1726, in the Gulliver's Travels, the book is for the first time it is described that machines could really think. 1980 we had the second AI summer. 2015 we had the third current AI summer start, and 2045 is the day that we finally have singularity. And singularity is that computers are smarter on any field than the humans. Just to give you an idea of how long AI is really amongst us, here is a picture of the Dartmouth workshop on AI. You can see by the look of the clothes that it's really a long time ago. And especially if you look at this picture, these are the same people with a picture of last year. Those are the founders of AI. So it's not that novel. It's really around for quite a long time. I already mentioned a little bit the second AI summer. And if you look at how the attention is for AI, you can see really a lot of changes in the popularity. And now I hope that this is working. Yeah, here. So 1955 is when, on the x-axis is the year. Let me explain a little bit more. And about the y-axis, there's enthusiasm or negative attitude about AI. And you see in the beginning, in around 1955, there's been a lot of fuss about the AI. Afterwards, that declined. And in 1980s, we had the second summer, we call it, with a lot of enthusiasm about AI. And again, that enthusiasm all disappeared. And now we're in the third summer of AI. Also, an interesting part is that we have different names for the same thing. So before the birth of AI, we were talking about thinking machines. And after the first summer of AI, the atmosphere was so negative about it, the attitude towards it, is so that nobody wanted to be associated with AI, with artificial intelligence. So at that point, people started talking more about machine learning and expert system. But now again, in our current summer, we talk about AI again. So we're now in the third summer. There's quite some differences. Usually I say the climate is changing, but a lot of people confuse that with some temperature that we're having. But also in AI, there's really a climate change going on. We have much more digital data, and well, what's most important for us, I think all, is that there is a much stronger focus on health in AI. Impact. I promise that it will be one of the main topics, but I will wait a little bit and come back to the impact of AI a little bit later. I go to the next basics, and that is about stroke treatment. And again, not to insult you, it is really that we are at the same track. So you know much more about this. There's a blood clot being formed as an embolus. It travels up to the intracranial arteries where it blocks one of the arteries, and then you have a stroke. If you look at, this is one of my favorite movies. This is an in vitro model of the intracranial arteries, and you see a clot, how it occludes one of the arteries. This is a movie from Noravi. This is one of the companies that make treatments. And in the beginning, for example, I really didn't understand how a thrombus could block a bifurcation of an artery. And here you see it really beautiful what is happening. So I also wanted to share with you this movie, because it so nicely illustrates what is going on in a stroke. So also treatment about stroke. I was really quite in shock, I must say, about what all happened in the stroke treatment. So it's already known for quite a long time. Already by Hippocrates it was described that it was a functional deficit at some point. It was also thought that it was a violent movement by the gods that is happening there. So it was already described quite a long time ago what stroke is. In 1600, it was discovered that there is a strong relationship between the blood and the brain, and I think that's also the reason why we're here in CARIM talking about strokes. Of course, very important. And already in 1800, there was some prevention for that, where the plaques in the carotid artery was removed surgically, so that the risk of stroke is smaller. So the shocking part is that there's only treatment that started around the changing of the century. So before that, there was zero treatment for stroke patients. If you compare that with cardiology or oncology, we were way, way behind in that disease. And only in 2015, we had a second treatment where a mechanical thrombectomy will be performed. And I will come back to that later. So really, compared to many other diseases, stroke was really slow. Cardiologists also think, well, you're so slow. You recently found out that stents work. Well, they know that for much longer in cardiology. So thrombectomy, we see a picture here. So we see a clot, here, occluding an artery. And with the thrombectomy, go with a catheter all from the groin up to the location of the thrombus, where we deploy a stent, and with the stent we remove that clot. And just to give you an idea of how large this clot is, I think this is a pretty large clot, Wim. It is about 1 centimeter long, but you also see the stent. This is after the retraction of the clot. And also a very special thing is that in the Netherlands we had a trial together with Maastricht, Rotterdam and Amsterdam. And I will say we, because I was involved for a little bit, we looked at the efficiency of that treatment. At that point it was not proven that it was an efficient treatment. And here you see the effect of this thrombectomy. We have a DSA, digital subtraction angiography, where on the left side you see that the contrast goes no further because of the blockage of the thrombus. The thrombus is being removed, and then the artery is opened again, and we can talk about a successful treatment. And the cool part for me is that not only this is a very successful treatment, but there was also a lot of imaging suddenly. So because there was hardly any treatment for patients with a stroke, only a CT scan was usually made. But thanks to this trial, and also for patient selection, there was now CT perfusion, CTA, DSA. We had so much more information of these patients. And that's also one of the reasons why I was so happy to join the Mr. Clean trial a little bit. So at some point, the Mr. Clean completed. We see here how successful it is. I will explain a little bit. We have here the modified ranking scale. For who don't know this, the dark parts are the healthy outcomes, and here you see death. And you see that with interventions, there are much more patients with a much better outcome than regular treatment. So it has an adjusted common odds ratio of 1.67. And here I was really confused because, well, I'm more from the technical side, from the AI side, and doctors tell me all the time, you have to make AI explainable, you have to tell the doctors what this really is. But if I tell an AI engineer that we're looking at the adjusted common odds ratio, they have no idea what we're talking about. So apparently, clinicians know to interpret this number, this this measure, where AI is more difficult. But this is more easy to interpret if you look at good outcome, if you have a large vessel stroke and you are still functional independent, we call that good outcome. With this treatment, we have about 1 in 3 has a good outcome versus 1 in 5 without that treatment. So that's pretty huge. So I'm sure that you were looking for me in that picture. There I am. And we also have our host Professor van Zwam. Have you found him by now? So I don't know what this says about our leadership, but I think we could maybe learn a little bit from the monkeys and to be more up front there. But maybe that's our modest attitude that we have in this Mr. Clean trial. So impact, I promised to talk a lot about, way too much about impact. This is a pretty huge impact paper. But all the time when I start talking about impact, I have this feeling. I talk about these new terms that is really important in the university. We have to talk about valorization. We have to talk about dissemination, about translation of our findings. I don't know if it happens with you, but if I am in a meeting with all my uncles and aunts and start talking about that, I really have the impression that nobody is listening about it. So it's tough. I will try to keep you interested in this, but it's tough to talk about it. But if we look at the impact that Mr. Clean had, it's really impressive. So many conferences that was presented. It was on the 8 o'clock news in the Netherlands. It made the front page of the New York Times, the Chicago Tribune. And even on page 12 of the Volkskrant, it was mentioned that there was a huge effect of the Mr. Clean trial. And here I am, and here Wim is. So notice that. So also to give an impression of what really the impact is, this is Jeffrey Dazen. Jeffrey Dazen was the chief editor, editor-in-chief of the New England Journal of Medicine. And when he left, after 25 years, he had 12 studies that, according to him, really changed medical practice. And I guess you already know what I'm about to say. One of those 12 main clinical changing trials and papers that were published, chosen by Jeffrey Dazen, was the Mr. Clean trial. So that's really impressive. And also, when we talk about impact, it's not only if some hospitals will take over it, it's really they talk about where is thrombectomy being used all over the world. So it's not only if some hospitals use it or some studies use that approach, it is really now where in the world, how available is this treatment. So that is, that's a good starting point to make impact, I would say. So I'm going back to AI, and AI has a really annoying characteristics that in every acronym they use, they make from an A, they add an I to it to say, yeah, it's AI, impact. I don't know how to pronounce it. And even in this word, you can make 2 AIs of it. This is really a typical AI acronym that you can see in many grant proposals. I hate it, but it's used a lot. So if you want to look at impact, we really have to look at the winters. What was happening? Because apparently all the promise that we had with AI, and there was a lot, did not really materialize. So there were 2 times already in our recent history that there was really a lack of interest in AI, no funding anymore. Labs have been closing, and a lot of AI companies actually went bankrupt. So what went wrong? And this is important because we really want to try and learn from our mistakes in the past. What happened with AI during the summers, winters? And just before that, there was a lot of promotion of AI in the media. Does that sound familiar to you? Yeah. There was a lot of promises of what AI could do in the media. Does that sound familiar to you? There were really high expectations from AI, and in the end, they did not materialize at all. So what happened already 2 times in our recent history is that there was really a chain of pessimism about what happened in AI. So a really nice example, I will show a couple of examples of how ideas of AI can go wrong in the impact, is IBM's Watson. Who knows, still knows IBM Watson? Yeah, here you see again the age difference that we had before. Who knows Deep Blue, who's playing jazz? Oh, okay, that's even more. Okay, just an idea. Deep Blue is older from IBM. Oops, let me go back. IBM Deep Blue is older. It was like a huge calculator, you know, the rule-based approach. So that's not considered AI. But Watson was made smarter, where a lot of language processing was included as well, and they could reason and interpret questions. So this was like the front runner of the large language models like ChatGPT. So IBM's Watson was very artificial intelligence. It won Jeopardy. I don't know if you know the game Jeopardy. It's in the US television. You get an answer and you have to think of the question. And here, the picture, it competes with the winners of the previous years. And by far, IBM Watson was smarter than any smart person in the US. So it was also applied to medicine. So a lot of medical evidence was given to IBM Watson, a lot of medical literature, a lot of data of patients, and they looked at how good IBM Watson was in diagnosis mostly. And you see here already an impressive achievement that for the diagnosis of lung cancer, IBM Watson was 90% accurate, where an average doctor was about 50% accurate. And even there was a case where the best specialist did not know what was happening with one of the patients, what was the disease that this person had, and where the specialist did not know, IBM Watson gave the right diagnosis and found out what the disease there was. So there was a lot of money invested by Watson, about 5 billion on acquisitions alone. I don't think it used to be a lot 10 years ago. If you see what the amounts that are going on and right now is not that much still. But as I saw already, the younger people, the younger than 30 people, don't know about it. So what happened with IBM Watson? So when we try to apply it, it was really noticed that in practice, the whole process was less efficient with after using IBM's Watson. So the doctors were less efficient this way. It was promised way too much. There we are again for the third summer. And again, the expectations that were given did not materialize. And as an effect, people were really becoming negative about it. So 7 years after the introduction of IBM Watson, they stopped it, and 80% of all the people working on AI, can you imagine? 80% of all the AI people at IBM were laid off, were sacked. And if you look now, whatever happened to Watson, you really get positive messages like this. By the way, I also noticed that self-driving vehicles hit bicyclists. I think they're not very pro-technology. But still, this is really the atmosphere that was created thanks to that. It was not just IBM. Some people still remember the Google glasses. So the idea was really cool that doctors could have the IBM glasses on, and the patient record would be projected on the glasses. So in the meantime, they could talk with slow-talking patients. In the meantime, they could read the records. You don't hear anything about it, and mostly because it got really hot on the side of your head. Google Health. Google really had the idea of building hospitals based on the search engine that they had. So the search engine is the center part of our hospital, and we just will build the whole hospital around it. You don't hear about it anymore. And there are many other apps that you actually have that are not successful anymore. So is it just a promise? Now, we have to dive into this a little bit better. So this is really important, what you see here. This is the CE certification and the FDA. And if you want to use software or AI in clinical practice, you need to have a certification of it. So you cannot just build an AI algorithm yourself, doing a medical task, and use it in hospitals. It really has to be approved by these companies or these organizations. If we look at, this is 1 year old, FDA, which is really more ahead than our European CE certification, has cleared about 500 algorithms about AI. So for me, that's not a lot. We have now 70 years of AI. Health is one of the main focus points of AI, and there are now worldwide only 500 algorithms that were approved. Still. So let's see where these AI algorithms focus on. So maybe some ideas. Are these the large language models, cardiovascular, or radiology? Some people ideas. And it's not just a small difference, right? You see here the different disciplines. Oh, I should point this way. Here you see this huge difference. So there's a huge dominance in one of the AI applications. Which do you think it is? Imaging. So radiology would say? Yeah, I agree. It's not, I think most young people would think more, well, the ChatGPTs, the DeepSeeks, etc. This is all radiology. About 82% of all AI algorithms that can be used in the hospital are about radiology. And some people might think now 82, this says 76. Well, actually this part, that's cardiology working on MRI, so that's really radiology. So 82% of all AI algorithms are about radiology. So we really have a front runner role here. So why radiology? Let's go back, really long time back, and there's a really strong connection between radiology and computer science, I must say. So the very first imaging, 3D imaging, 2D imaging devices required a lot of imaging. So CT stands for computed tomography, a lot of computations. And here you see also that one of these CTs requires a lot of computations. So speech to report, you see a lot of AI applications now that make reports out of the conversations with patients. This has been around already for 40 years in radiology with speech to report. The digital department, or all the data that's really digitalized, it's been already a long time ago, 25 years already in radiology. So many departments in hospitals are now really trying to digitalize everything. Radiology was way ahead. And I don't know, do people have shares in NVIDIA? Not too many. So, yeah, as scientists, we don't care about money apparently too much. But so NVIDIA, before it was the AI chip, it was really on computer games, the virtual reality, 3D rendering. I don't know if people do first-person shooters and stuff, where you run around in worlds and shoot people there. There's one, thank you. So this is where NVIDIA came from. NVIDIA came from 3D rendering. And also in radiology, you see here really nice 3D images of patients. And that's all done by the fast computations of the graphical processing units of NVIDIA. So if that's why other radiologists are so rich, they already saw what was happening in NVIDIA, and well, I don't know. So it was not, it was observed by many already that AI had a lot of potential in radiology. And not just because radiologists are so expensive, but also because it was the early part, the third AI summer was really focusing on computer vision, on image analysis. So when the third AI summer started, many news items started about how computers will replace radiologists, and that histopathologists and radiologists should stop their profession, and because the computers and AI would take over everything. That was already 10 years ago. I don't know if you saw the years of those messages. This was about 2015-16. It was mentioned, promised, that AI would take over radiology. We're now 10 years further ahead, and I think this promise was not materialized, right? It was too much promised. So here we are again. We are the third time that we have a positive attitude towards AI, and again, what we do, we promise too much, and we promise so much that it cannot be materialized, because we still have radiologists. Why? What happened? There's a lot of interest, but not many hospitals buy the AI. Also, a huge issue is that the reimbursement is not organized well, and it's also because issues like liability has not been arranged, and often there was no proof of there's really added value of AI, and also the integration of all the AI in clinical practice was not often done. Just an example of where we are now. I think it's another paper of last year. It was a huge study where they looked at the value of AI in clinical practice. So they looked at lung scans, about 20,000, and they integrated a lot of AI in it, and they trained all the radiologists to use it. And what was the gain that they had? That an average of 15 seconds that they would spend on looking at one of those images, they could reduce it to 30 seconds with the AI. But if there were complicated cases, even the time would increase, and it would be even slower. And after this full study with all those scans and all these radiologists, the gain that the AI brought was 11 minutes per radiologist per month, which is less than 1 cup of coffee that they drink in a month. So that was, well, kind of disappointing. That's not what the AI promised to do. And, but again, this is a very typical observations that we have. So what is happening here? So here I start talking about my valorization translation part again. If you want to translate your technology, you have to go through a number of steps. So first you have an idea, but you really want to bring value in for society or for your hospital or for the patient. So what usually happens, this is the most fun part, epiphany. Eureka, you have an idea. There's a problem in the clinical practice. we have AI, it could be solved by AI. And then another fun part is we make an AI model to solve that problem and see if we really can solve it. Next step is very important. We validate it. Does it work in practice in other hospitals? We have to test it in real time, and we have to integrate it in the whole radiology workflow, and eventually you have to evaluate the outcome of this AI tool that we have developed. If you now look at where the attention, where all the money, where all the papers are going, do you have any idea where those may be? Development, yeah. So this is a study, and I will explain again what you see here. Here you see the years, and the circles give the size of the circles give the note of how many studies are being performed in that direction. So what you see is that almost all the money, all the papers that you see are about the development of an AI model. And then you really miss a lot of parts to create the value in the clinical practice, because there's hardly any attention going in that direction. So let me give I will give another two examples. I don't know if you saw this in the news. This is Delphi 2M. Delphi 2M could predict over 1,000 diseases, and it was really concerning. It made a lot of news, a lot of PR. All the news channels mentioned that this was. It was also published in Nature, so huge effort, and also with a lot of patients. And the idea is that we could create that. If we really look at what the study says, it is Nature. It is really great work. But if you look at the accuracy of predicting an event that really happens, it's about 70% accurate. So you have 1,000 diseases. It has a lot of attention, but only 70% of the predictions of any patient is actually accurate. And if you look further than 2 years, it's about 14% accuracy. So this is a study, an AI study, that has a lot of attention. A lot of people got worried. They said, oh, but now I know exactly what diseases I will get in the rest of my life. And yet there's only 40% accuracy. Also, this made a lot of news. The thin cap identification in coronary arteries after an ischemic, after a myocardial infarct. AI was absolutely better in identification of those thin caps than the humans were. Excellent work, and very good AI work, and you see here indeed that the accuracy of an event, of the prediction of event with AI, which is the red line above there, is indeed much higher than the human identification. But still, you need an OCT for every patient, and I have a friend who got a myocardial infarction. He was really worried because his images were not diagnosed by AI, but by a doctor. So he phoned me directly saying, help me, use your AI, because my images were processed by a human. But if you look at this is really research-based. And again, if you look at this chart with all the steps that we need to make impact with AI, the newspapers, the news items that you see were all about the AI development. And you should realize that whenever you see something like that, often it is about the developed AI model, which can be very accurate, but still not have that much value. Yet there are success stories. There are really reimbursements for some. For screening, it can be really valuable. But again, if we look at how much effort it takes to get those valuable AI model, make this calculation on the right. We have about 400,000 AI engineers working on medical applications. About tens of thousands papers are published. Of those tens of thousands models, there were about 500 certified by FDA or CE, And of those 500, only about a number of 20, 30 of AI models are really valuable. So the chance of getting something valuable out of AI is not huge. So, a long road. I will tell a little bit about myself. This is my natural habitat. I don't feel really at ease showing this picture after seeing all those pictures of monkeys before. I have now the idea that it is in the same realm being observed, but this is where I feel comfortable. Also, this is probably why AI researchers are much more negative towards each other than clinicians, because we don't communicate that well. We don't. That's something I learned again. But this is what my work was like. I looked at pixels, and I looked at every pixel and what it's like. And if I want to look at the skull, segment it, I have those rule-based algorithms going on there. And this way I can segment coronary arteries that you can see here, and also kind of other parts. Here we have a CTA, whereas a stenosis, we can segment that part, we can determine the degree of stenosis, and this is the work that I was working on. And again, I was a little bit involved in the Mr. Clean. I was allowed to do anonymization of the CT scans and collect the data, but there was a lot of fun because there was new data that was never seen before. And we could do a lot of fun stuff with that. For example, we could measure the infarct after a stroke, rather than have an estimation. Just to give you an idea, the measurement that used to be done was, is the infarct larger or smaller than 1/3 of the hemisphere? With image analysis, we could really quantify that. And if you look also on the image on the right, you see these patient with good outcome had a much smaller infarct than patient with large outcome, so very valuable measure. Collaterals is also important in stroke. Also, the collaterals have a huge influence. There are some collateral researchers in the audience. Here again, radiologists have very crude scales, 0 to 3. But with measurement, if you look at the pixels, we can really do quantitative measures. And we can measure how much contrast is in the contralateral side and see how much capacity the collaterals have. And just to give you an idea how well this coincides, we have here the crude radiology scale, and we have the quantitative measurements. They coincide very well. And if you look at a prediction of how well a patient comes out of the models, we have the quantitative measure. It's really more accurate than the crude radiology scales. We look at the thrombus. That is an important but really difficult task, because we have to tell the computer where the thrombus is and where there's lack of contrast. So we see here contrast, which means that the artery is open, but we want to find the location of the lack of contrast. That's not easy to tell a computer, but we did. And also with those measurements, we could do another way of measuring it, the thrombus characteristics. And what we actually saw, that if we look at the CTA, so where contrast was added to the patient, that the intensity was really higher sometimes for some patients than the regular CT. And in the beginning, I must say that I was a bit angry with my PhD student, and I thought that she made huge mistakes. And I just redid all her measurements, because I thought she made a huge flaw in it. But actually, this is something that we saw. But it was not something that we expected. We really saw a thrombus as an occluding object, where, like a cork in a wine bottle, where no contrast was going through. But still, we saw additional contrast. And it's not strange that it was a bit of a surprise. We look at the at the digital subtraction angiogram. Here you see more or less the artery. And usually the intervention radiologist wants to know where the thrombus is. So that's where the contrast stops, and that's all the information that is needed to start the treatment. But if you look a little bit further and longer, then you see really that some contrast is really going through the artery and also going distal. So, and you can see it even better here, where I masked out the artery, here the thrombus. You can really see some contrast going through the thrombus, and that was something that was quite unexpected at that point. So it could be that the thrombus was permeable, and we called this at that point perviousness, because permeability, you really have to measure that. And if you look at the permeability and if you compare that with the outcome of patients, we also saw a really strong relationship with the healthy patients, which had much more permeable thrombi in their head compared to patients who did not survive. Also, if you look at the relationship with the thrombus permeability and the infarct that was created, we also saw a strong relationship there. Okay, in the meantime, when I was having fun with the Mr. Clean data sets and find all kind of quantitative measurements, the AI summit, third AI summit was starting. And what was different there is that instead of all those smart algorithms that I spent a lot of time on, we really get rid of that, and instead of that, we use data. Only data, we give it data, and you tell the computer, I don't mind how you do it, but find some kind of relationship. And that was started with the ImageNet, and we had sometimes really difficult tasks by separating those dogs. I always forget the husky and another dog. Well, I see that not everybody is really good in that as well. But computers were at some point better in this than human observers, and I can see now why. And so we also started looking into this, and this is my best illustration. We had a really successful and really smart PhD student who looked at the quantification of this hemorrhage. You see here an hemorrhage, and we want to know how large it is. At the same time, we see here also some shining through of bone. So the task that we give a computer with our methods is that we really look at, we say, okay, this pixel, this information is blood, and this information is, what you see here on the right, is bone. It took a very smart PhD student about a year, but she had the study done, very nice results, paper was published. An AI student came by, and it took him 48 hours to do exactly the same. This is what AI can do with my job. Not with the radiologist's job, but with my job. So instead of doing smart things with algorithms, just the data would use that. And at that point, the deep networks were really increasing a lot. And with many, many medical applications, those deep networks were applied. So we also developed AI, again for the finding the thrombus, and we were quite happy with the results, also because it is a huge task, as you can see. The volumes are really large, and you can see really how difficult it can be in such a large volume to find this really small dot. And even in non-contrast CTs, we could find the thrombus. And I asked radiologists to find the thrombus in this CT scan, and of course, they are too much biased, but I'm wondering if you can find the thrombus in this image. Maybe Wim sees it, probably. Yeah, it's difficult. So this is the thrombus. So this is what the AI can accurately do. Now, the first time is the hardest part, so now you know how to look at it. Anyone seeing the thrombus? There it is. So this is a difficult task, and so we can train the AI to make this to do this difficult task actually by having a lot of examples. So we had something that could be really valuable, and here I started talking about valorization again. How do we do this? And at some point, here we are again, AI imbibed. We looked at how can we make sure that other hospitals and patients can make use of that. And here we have the TRL level. I'm sure that most people know of this. You have different steps of how developed your technology is. Oh, we can work at this as well. And the The main part is we usually look at really the early part of the technology development and demonstration. The part afterwards is not something that a hospital or a university usually does, also because it's really expensive. You need very different people, quality engineers, software engineers, testing engineers. That's not something we have. So how can you do this valorization? There are a couple of ways to make really value to society. And I will focus on the inside-out part. And inside-out is that we have knowledge inside our institute, and we want to make sure that it's valuable for others. And how can it be valuable? What happens if you have a stroke? You get into the ambulance, you get a CT there, and often to an initial hospital, often at night, where only junior radiologists and neurologists are available. So sometimes you have to call them. And sometimes if you have really a large stroke, you have to go to a treating hospital, again with the ambulance, where again a CT scan has been made, and other experts have to look into that. What we did is that we did all the algorithms that we developed, including the detection of the thrombus, the collateral scores, and gave that to the radiologists and neurologists really at the early times. So really, as soon as a CT scan is made, it is being sent to analysis. The AI will calculate all the stuff, put it in an app, and make it available for analysis for the people. And the good thing is that it has been evaluated, and it's also cost-effective, this part. So we started a company, spin-off one, so that's why I'm so positive about it. And the fun part, also for the senior researchers here, you can still keep working with your bright PhD students. So here are some of the people who are at Nicolab, our company, and some former PhD students are now in that company, and we still work with that. It's now 10 years since the company was started. We have processed more than 100,000 patients with our software. So that's really impact that has been made with that. Time is running out a little bit. I will briefly describe our next topic. And that is that we want to look at the stroke detection a little bit earlier and already in the ambulance. So we were thinking, why don't we use EEG for the stroke detection already in the ambulance? And for that, if the ambulance personnel has these EEG analysis, they can see, is this a large stroke? Do they need to go to the closest hospital for thrombolysis or to a specialized hospital with endovascular treatment? So we made this smart bathing cap, that we call it, slimme botnuts with dry electrodes, and within 2 minutes we could have the analysis made of that. And we showed in one of the studies that we have a pretty good accuracy in detecting the stroke already at a really early phase, so that we can know to what hospital we're running. So this is EEG that we have. So do you people know what kind of stroke this is? It's left or right-sided, M1, M2, large vessel occlusion. Of course, now, the ambulance personnel, would they know this? They see one patient on average per month with stroke. So now this is really a task for AI. You can have, again, a lot of data involved. A difficult task for some people that don't use the data a lot, and then AI can tell you this is an M1 occlusion, right-sided, and then we can know what to do. So as soon as you have this idea, we have to develop again a business case. These are all new things. We have to think of key relationships with buyers. We have to think of customer needs analysis. But I have to admit that a customer value proposition, it's really good for researchers as well, to really think of when is something valuable, how can we offer it to a patient or to a potential customer, to really pinpoint on what we should be working on for how long. And then the fun part is we get a coffee mug with the new logo, we have an office, and we again can start up a new team. I will now, and I know that Joost will be really happy, I will skip the digital twin part. I just wanted to share this, and this is of course something that we're really proud of. We were the most positive news at nu.nl because what we developed. So that's again a lot of PR and relationships, and also that came abroad in a lot of press. So since then, everything changed. When I really started talking about the companies, about the valorization, everybody is really interested in what's happening, and I'm happy to do it that way. So I'm sorry for skipping the digital twin parts, and I will just leave you with some final thoughts. If I can find the mouse pointer. So then I have to go here. No? Oh yeah, sorry. So next time I will talk about digital twins, no problem. I just want to share my last thoughts about this. Why? There, oh yeah. Some demo message. So be aware, AI is developing really fast. It's already fast for 70 years. 70 years. And often the real impact that AI is making in the clinical workflow is really not that big yet. So we have to learn from that. If you talk with AI researchers, or if you're reading new AI solutions, you're probably reading research topics rather than really implementations of that. And indeed, it is fun to start a spin-off company. You can keep working with the smart researchers and really create value for patients and clinicians. I think I will leave this to that.
You and I, mostly you. Yeah. There is time for one question, I think. You can ask about anything, except for digital twins, I think. Is there a question about AI in general, or AI in health, or AI in stroke even? Anyone? Yes, here. I give you the microphone.
Hi. Interesting talk, thanks. So I read more and more news now that there's supposedly an AI bubble that's about to burst. So you may not be the person to ask this, but I'm asking it anyway. Do you think there is indeed that we are putting too much trust into AI and eventually it will burst and we're going into a recession, etc.? What are your thoughts on this?
You were the one.
I don't have shares in any.
Did you have the shares? No. Oh. Yeah, we did the calculation. There's been put more money in AI for radiology than will ever be spent the coming 20 years. So for sure, not all the money will get back to the investors and the shareholders. So some people will be less lucky than the NVIDIA shareholder that we have here in this room. Yeah. How large this bubble? It's also with the internet. It was an internet bubble. We still have internet. Okay. We will still have AI in the end.
Thanks.
Anyone else? Before we go on, yes, one more there. Yes.
Yeah.
Yeah, indeed, I'm a bit disappointed I missed the digital twin in your talk, but no.
Oh, but let me...
No. So I really like your numbers from, going 100,000 developers, then the papers, then going all the way down to very little FDA approved or regulatorily approved tools. But in the development, it's not always necessarily the goal to lead to a tool that really does something useful. There's a lot of indirect impact. How do you think about that? It's a great research tool as well.
Absolutely, I completely agree. Yeah, I agree. Also for me, when I do a lot of image processing, we all do everything with, let me get one more slide. We do it with AI nowadays. It is so much faster than anything else. And it's really valuable for a lot of research. But a lot of people are talking about how AI can change health. And if we talk about impact, many people, a lot of my AI researchers are asking, why are the doctors not using my AI tool? Well, there are thousands of reasons, but that's true. Impact is very important, so we have to think of it, but you can make impact of other ways as well. And I just was hoping that I could get one more. Oh yeah, there. And of course, we had our former Minister of Health who were thinking that all the problems in healthcare will be solved with AI. And I want to distance myself from that statement.
AI made her redundant.
We have AI ministers in some countries.
Okay, before we move on to the next session, we have to present you something as a thank.
Oh.
It's an AI impression of an Nordic arch.
Ah!
Very interesting one.
But you can see something else in it.
Yeah.
And if you like the art, you can keep it like that. If you like the price, you can put this on one. This is like the name tag.
Oh, cool.
This is easy to lose. This is not. So
Yeah.
And thank you very much. If you look at the camera, thank you, Rob, also for the opportunity.
Fantastic work.
Congratulate you with another fantastic lecture in your name. And we salute you, Rob.
Thanks so much.
Even de foto met z'n drieën. Jij in het midden.
Oh ja.
Goed.
Oeh, zwaar.
Dat is zwaar, hè?
Ja, mooi.
Ja, dus dat is alleen Harry. Harry. It's up to you now. So you're alone? There's no one else from the Health Foundation team?
Yes, there is. They're always around.
They're always around somewhere. Hidden. Maggie,
Of course in the back.
welcome.
She's joining. Dankjewel.
Heb jij een dia of zo? Heb jij een dia of zo? Maggie, is there a slide?
Yes, there are.
See?
A slide. Let me say in the meantime, you didn't talk about quality of life of doctors and researchers after the introduction of AI.
Oh, that's another very interesting topic. There's more depression going on in radiologists after the introduction of AI.
I would have guessed the other way around, but okay, no. Yes. This is about the Harry Crijns Research Grant. You know, I'm here every year at CARIM Day. And it's a typical prize you can win when you are turning the first page of your research. So you're a master student. This year we've got a master student who has won the prize. And you're very frantic about research, doing research. That's what you want to do, but you're not ready with your PhD yet. If you're in the first stages of your research, you can apply for this prize. And it's always very enlightening and also very, I always get a warm heart when I see all the applications. They are very good, a lot of enthusiasm there, so please send in also next year. And it makes the task of the committee to select the candidate very difficult, right?
Absolutely.
Maggie? And this year, well, I must say this Research Grant Award is provided by the Health Foundation, Limburg, and
some support.
And some support, yes. I shouldn't forget, I always have to read it out loud. It's also in your program.
It's also on the slide, very big, Harry.
I can see it.
Ricordati.
Where is it? Oh, it's to the left, yes. Those are the supporters. It's not, that's not unimportant, it's very important, but we are very much supported by the Health Foundation Limburg. Now it's important that we ask Cas van der Heijden to come forward. There he is. You can applaud him. He is a master's student devoted to peripheral vascular disease. So he is in the team of Van der Water, Dr. Van der Water, and Professor Mays, right? And you have been doing your studies now since 1 year, 2 years?
No, my final year of medical school right now.
Yeah, final year of medical school, but how long are you doing your research at present?
1 year, 1 year ago.
1 year, okay. So very successful in only 1 year. And I'm going to hand you the Harry Crijns Research Grant. It's 25,000, and we're going to make a picture. Okay. So you.
Goeie. Zo maar, trillen, Harry.
Congratulations. And now I invite him to give a presentation, or is this? You took a presentation with you, right? And so take the floor, and good luck with your research in the next years. Thank you very much.
Gefeliciteerd.
Thank you, Mr. Crijns, for the warm welcome and the grant, of course. So my name is Cas van der Heijden, and today I will talk with you about the research I am going to do with the grant. But first, I want to start with the case, and this is the case of Mr. A. Mr. A is a 77-year-old man with a medical history of smoking and peripheral artery disease. The daughter of Mr. A calls the general practitioner at 4:30 p.m. and she tells him that he has a wound on his toe. The wound has been there for a few weeks, so the GP asks Mr. A to come to the practice. After assessment by the GP, he makes a referral to the emergency department because the wound has been there for a few weeks. After assessment in the ER, the vascular surgeon decides that the toe needs to be amputated, and the amputation takes place the same evening. Mr. A gets admitted to the vascular surgery department. However, after a few weeks, the wound hasn't healed, and despite all effort, a transtibial amputation is needed, and Mr. A loses the ability to walk. Before I go on, I want to ask you, try to put yourself into Mr. A's shoes, that in a time span of a few weeks, you lose the ability to walk. What quality of life have you got left? What about your autonomy? And what about health? We know that walking is quite an important protective factor for disease, especially cardiovascular disease, and also mortality. And what about your self-reliance? People who can walk also bring a lower healthcare costs and put less pressure on the healthcare system. Walking also stands for social participation and stands for freedom and independence. So it's more than just putting yourself from A to B with your feet. First, peripheral artery disease. PAD is defined by the partial or complete obstruction of one or more peripheral arteries, as seen in the upper picture. PAD affects an estimated 200 million people worldwide, and the primary cause is atherosclerosis, which is the buildup of plaque in the artery wall. Common symptoms of peripheral artery disease include intermittent claudication, so pain in your legs after walking, rest pain, and tissue loss. The categorization is used using the Rutherford classification, as seen in the table. The end stadium of PAD is CLTY, chronic limb-threatening ischemia, and is used as the Rutherford classification 4 to 6, so rest pain or tissue loss. Treatment often includes revascularization procedures, but also minor or major amputation, with minor amputations being below the ankle joint and major amputations above the ankle joint. The disease is known with a high mortality of 40 to 60% in 5 years. Diabetes also plays a role in this case. 1 in 14 people in the Netherlands have diabetes, which is approximately 1.2 million people. And patients with poorly regulated diabetes often have non-healing ulcers for which an amputation is needed as well. The diagnosis of CLTY, patients with CLTY often have diabetes as well in 2/3 of the case. So we've talked about amputations a lot, but this brings a big substantial burden to patients because the need for an amputation in the first place sets the need for a subsequent amputation at approximately 30%, with some studies even reporting 50%. 1/3 of these higher level re-amputations are major amputations, with patients losing the ability to walk. And this brings a profound impact on the quality of life of patients. But mainly it starts with just a regular toe amputation. There are about 7,000 amputations performed of the leg in the Netherlands, of which 2/3 are minor amputations. These are often performed by a young surgeon during on-call hours in the hospital. Up until now, there's no clinical data on preference for amputation technique. There are 3 techniques described, and they're used across in the hospital. So the upper picture shows the MTP disarticulation through the MTP joint of the foot. There's also the possibility to remove the cartilage of the metatarsal bone, as seen in the middle picture. And the below picture describes the transmetatarsal ray amputation, where the head of the metatarsal bone is decapitated. As I've explained before, these patients know an intensive and care-dependent follow-up with a lot of regular checkups in the hospital, but also the need for revascularization procedures and even re-amputations. Up until now, there's also have been any consent about the perioperative care surrounding these amputations, where patients should get antibiotics, or if the wound should be closed or not, and what about offloading strategies? So, as Mr. Crijns already told this, I've started with my research internship with this study, and retrospectively in the MUMC, we've included 178 patients with CLTY with a toe amputation from January 2018 up to December 2023. The median wound healing of these patients was 83 days, which means it took almost 3 months for half of the wounds to heal after a toe amputation. Almost 30% needed an additional revascularization after the primary toe amputation, and almost 30% needed a second amputation, of which 25% happened within the first months after index surgery. Almost 8% needed a transtibial or transfemoral amputation and thus lost the ability to walk, of which 4% happened within 6 months after index surgery. And this paper is currently under review. So our plan is to set up a prospective multi-center RCT in which we investigate the influence of amputation technique on wound healing, as well as complications, re-interventions, mobility, and mortality. And we hypothesized that the amputation technique will have an influence on these outcomes. A proper toe amputation will prevent a major amputation. Currently, there's no prospective comparative research regarding this topic, and the prospective and multi-center character will have a great influence on the reliability and applicability of the results. We're going to set this up in the vascular network here in Limburg, in which the Zuiderland MC, the Laurentius, Vicarie, and the MUMC will participate. We will randomize the 3 surgical techniques, MTP disarticulation with cartilage removal, and the transmetatarsal ray amputation, 1 to 1 to 1. We will also harmonize the perioperative care in these amputations, in which we give each patient antibiotics after surgery, we close all wounds, and we take cultures from these wounds, and each patient gets an after treatment with plaster. To maximize inclusion, we will include all patients needing a toe amputation due to CLTY. Only exclusion criteria which are set are an amputation due to trauma, or the no possibility to give informed consent due to delirium or dementia. The primary outcome of the study will be the wound healing status on 30 days post-operatively. And we use this outcome because it's clinically more relevant and we can act more early. Secondary outcomes are also the time for all wounds to completely heal, complications being complications during admission, but also local wound complications, re-interventions at 6 months and during follow-up, so revascularization procedures, but also higher amputations, mobility and mortality at 30 days and during follow-up. The goals of this project. First, we want to map out the risk factors for these patients so they can get more personalized care and see which patients will even benefit from an amputation. Harmonization of the perioperative care is also one of our goals, because right now there's no consent about this. This study will make sure we can improve the surgical decision-making around these toe amputations, because a proper toe amputation will prevent a major amputation for these patients to keep walking. It will also make sure the patients have a better quality of life, because they still can walk. And it will improve the scientific collaboration here in Limburg. We've already started with the preparations for this project, and before the end of this year, we want to make sure we hand in the protocol with the METC, and then we have 3 months in order for the local improvement in the regional centers. Then we have 1 year to include the study, in which we try to include 130 patients, and then we have 1 year for follow-up. After that, we have a few months for the data analysis. We will research in the following team, with Dr. van der Water being the principal investigator, and as already told, we have coordination help from Prof. Mees and Ms. Vleugels here in Maastricht, and we also have the vascular surgeons in the regional center, which make sure the protocols will be followed. Then, why me? I've got a lot of passion for this subject. As I play soccer for already 17 years now, it's a big part of my life, and of course walking is then too. As I'm at the start of my career, I'm an enthusiastic researcher, and this project gives me a lot of energy, as it's already a big project, and I will make sure I can finish it. It's also the start of a 2 to 3 year plan for my PhD project, in which I will also investigate the ability to walk after re-amputations, together with the rehabilitation department. I will perform a systematic review on the 3 different techniques in this project. I will also investigate the quality of life and well-being of patients after major amputations, and have a look at the care of patients with diabetes, because they need a whole different approach. So, I firmly believe this project will make sure people as Mr. A can keep on walking, because a proper toe amputation will prevent a major amputation. Thank you for listening.
Thank you very much for your presentation. Well done, very enthusiastic. Is there time for questions, or what's your point?
It's your choice, Harry.
Okay.
Go for it. A short one. Maybe.
One short question. The point is, you're doing a randomized study. How are you going to evaluate your primary endpoint? Because it's wound healing, so the extent of wound healing.
Yeah,
is there maybe a place for AI to to objectively compare the 3 regimens you take?
Yeah, that could be.
Okay. If there's no more questions, thank you very much. And as I said, good luck with your research in the next few years. Thank you very much.
Thank you, Cas. Do not leave, because I would need your services later. So please get your chair back. So now we come to the exciting session of the CARIM awards and priori, and also wrap-up. And I would like to invite Lisa Den Brok and Stan Muitjens to the stage to disclose the winner of today's contest. And while you're doing that and setting up, I would really like to thank you both for proposing this constructive and stimulating initiative, and also to tell you that we also always listen to good ideas. And so this was granted, and I think it's already a great success. And in that respect, I also mentioned the very successful postdoc retreat that we had this year, also coming from the postdocs, talking to us, and we support every good idea. And if it costs more money, we even greatly more support this. So money is never an issue with CARIM, so if you have a good idea, come to us. So we're located at a new location that's just above the student Mensa. So it's Ans 40, second floor. So next to the coffee machine, you go into the stairs, you come up to the war room. And very soon there will be another reason that you would like to visit the war room, but that's also still a secret, so we'll disclose this a little bit later. Go ahead.
Thank you, Tilman. Great to hear that also money is not going to be an issue, so we'll come back to you as soon as possible for next round.
Next year, yeah.
Yeah, for next year. But without further ado, I want to thank everyone for also participating, for those that attended and applied for this new round that we wanted to initiate, for the people that helped with the organization, but also for everyone that voted. So we're first going to show the score that we've given as a committee over the whole course of the whole trajectory that people went over. Oh, it ended.
Oh, it's still hidden.
Extra spice. Heb ik hem uitgedrukt? Oh! Nee, oké. And then we do this and boom. So, extra suspense. So like I said, the first bit of score that we're showing now is done by the committee. Overall, the scores were very positive for everyone. So even the ones that did not make it to the final round, they all scored very high, but we can only have a top 3. Now looking further into the final scores, that too did not make a big difference. And as we can see, eventually Anouk became the winner of this first edition that we had. But we still want to invite also Ilse and Eileen to come over, as well as Anouk, to receive their prize. I'm missing one person? Or?
Yeah, Eileen is, I think, not here anymore, but I think her supervisor will take
Ah, Sebastian.
Yeah.
Great replacement.
Ja.
Daar ga ik anders wel voor je staan. Ja.
Thank you very much, Lisa and Stan, and congrats to all the winners. All right, the final session, the CARIM Awards, and we will start with the prizes for the HS BAFTA, the Harry Struiker Award for Talented Academics. And I hope Harry is still in the room. I see you sitting there. And the 4 recipients already know this, but for the rest it might be a little bit of a surprise. So I think the Harry Struiker Award for Talented Academics is one of our best programs that we have to stimulate young talent. So we have them in 3 flavors. We have the pre-PhD, so as a bachelor student, you can take 1 year off and work in a department of choice, fully paid. Also as a master student, you can do this as a pre-PhD. You can take a year preparing for your PhD, writing a grant and see if it's granted. And then the other one is for the active PhD candidates. So they can take 3 to 6 months abroad at a famous international institute that we have bonds with, to get cultural and scientific exchange and bring back ideas and new techniques to CARIM. And this is really a powerful one, because then it also makes you eligible for the Rubicons and later on the VENI, because you already get significant foreign experience as a researcher. So this is a very powerful one. This year we only have 4 of these candidates granted. And then also every year we have a postdoc that can go abroad for 1 year and then come back for a couple of months to CARIM to write a report about it and see what your possibilities are within CARIM. But for this year we have 4 PhD students, and their pictures and names are here, and I would like to invite them front to get their medal here, and we have the classic Greek-Roman model, but we also have like a modern bling-bling one, so you can take one of your choice. And while you're here, Harry, maybe for the picture you can join us down here. And so please come forward, Nick, Pepijn, Madelon, and Mobina. Congratulations. Gefeliciteerd. Jij ook gefeliciteerd hoor. Pepijn. Nina. So, here are the sets. You can pick one of your choice. One is not more worth than the other one. It's not gold. So, yeah, you can take one yourself because you take the gold one. I knew it. Allemaal de bling-blinks, hè?
Uitzondering, 1 keer.
Huh?
1 minuut het woord willen voeren.
Ja, heel graag, ja? Zeker. Geef je de microfoon. Let's first make the picture. Oh, is it okay? Not visible? Stay here. Hoi.
It's not my habit to talk to the meeting in the CARIM Day, yearly day, but I would like to use this special occasion to congratulate these very youngsters here in their prize, but to take you back to a November day 50 years ago, which was in 2024. So just before the 50 years of university. Mm-hmm. And already at that moment, 4, at that time, relatively young people spoke together to create a research institute under the leadership of Rob Reneman, who is the real senior here, and I presume he is present with us.
Yes.
Via the internet. The other ones were Koen Hemker and Hein Wellens from the cardiology department, and Koen Hemker from the biochemistry department. And we decided at that moment that it would be wise to not have independent departments working on their own, but to create an institute, which was to become, under the real guidance, again, of Rob Reneman, the CARIM. Today, we heard the new director of CARIM, of several years already, but the present director, formulate the ambition to make CARIM the best research institute on cardiovascular issues of Europe. And I would fully agree with that, but I would like to say to these youngsters, not only to be the best cardiovascular research institute in Europe, but to work with all the other very good research institutes in Europe. That is probably the best mission of becoming the best, to work with the best.
Rightly said.
And with that, I would wish you a further long period of a very good existence of CARIM and a productive research.
Thank you, Harry. All right, thank you very much. Then we'll continue this session. Dank je wel, Harry. So next we will come to the poster awards. And first I would like to ask a big hand for our poster judges. For Division Blood, Jordi Kokke en Miranda Nabbe. For Division Vessels, Bart Spronk en Lieve Terreman. En for Division Heart, Magdalena Rokova en Yannick Nielen. So we asked the judges to judge the posters 50% on their presentation. So that's like having the X factor, get the message across, and be clear and concise with getting your message across. 25% is about layout, and only 25% is about content. So everyone has the same chance to win. And the winner of Division Blood is Jip de Kok. Can you come forward, please? Here's an envelope. I think there's money in there, so you don't have to spend it on a conference or on courses. You can bring it to the pub and then enjoy your time.
Very good, will do.
And you can stay here. Then we make a group picture later as well. So for division vessels, I would like to invite Lia Bika. With the pub envelope. Congratulations, Lika. Alsjeblieft. And then finally for Division Heart, Peter Deisler. Peter, congratulations. Yeah. Let's make a group picture. Well, you want the CARIM logo again? Yeah. I'll stand next to it. Why don't you stand in the middle, Leah? The CARIM Thesis Award. Again, we'll get our hands hurting later this afternoon. I would like to have a big applause for the jury of the CARIM Thesis Award. Eline Kooi as chair, Casper Schalkwijk and Uli Schotten. It's always a lot of work to go through all these theses to find the pre-final selection and the winner. So a big hand for the hard work. And as shown on the screen, last year we had 58 theses. It's quite a stack. There were 6 nominees from out of the division leaders, and there was only one winner. It was a close call, but they made a real good selection. And the winner of this year's thesis award is Dr. Jeremy Weerts. I don't see anyone rising. He's not here. Okay. Esther's. Sorry? Hij is niet. Okay. I had some interesting pictures about like a stressful day in his career, like sort of a pre-final meeting. If the PhD thesis would get there in place and in time. You can see a lot of chapters that are still under development, have to be submitted, are in preparation, and can see his promotion team there frantically on a Zoom call next to it. And on the next slide you can also see him with Loop met je dokter, Mens sana in corpore sano, and I found a really nice free proposition that he included in his thesis. Life can only be understood backwards, but it must be lived forwards, and I could not more agree to that. So unfortunately, he's not here, but here is the award. It's a beautiful piece of plastic with his name inscribed in there, and I'll put it here for the picture with greetings to Jeremy. Then we come to a very interesting phenomenon, and that is what we introduced a couple of years ago, and that is the CARIM priori. So it's basically we draw 2 members of our CARIM community to be part of the executive board of CARIM, and they can have a year with us in the executive board to decide what we're going to do and how to keep our ship floating. And it's basically aimed at a period in Florence, an intermittent period where the Medici did not rule, and they had a city government also by choice. And if you look at the blueprint of what was going on there in Florence, it really looks like CARIM. So the Signoria is actually the executive board. We have the Dodici Bonimini that looks like the CARIM Strategic Board. We have the school council. So the whole setup in Florence at that time looked like the setup, the organogram of CARIM. So we decided to do this also with CARIM. So we will add 2 people from our CARIM community every year. And we're going to do that by draw. And this year we had officially 592 CARIM employees with a P00 number. From those, many are PhD students, from those 156 were structurally paid without the CARIM board, of course, and the office members. We had 87 males and 69 females, and this keeps on correcting to a 50-50 modus if you look compared to when we started, and next year I will show how this develops. And from those 156, 102 are scientific personnel and 54 are support staff. So we have 2 pouches. We have a male pouch and a female pouch, and they're here. They're locked. The keys were brought to me just by the notary, and I would like to ask Cas down here again to assist me in drawing 3 members from the male and 3 members from the female boards now. Krijg je officieel de sleutel. Mag je beginnen met de vrouwen. Je moet er wel een beetje roeren erin, hè? Huh? 3 per zak, ja. Dan moeten ze goed, 1 voor 1 moet je ze aan mij geven. This is always a very exciting moment. Especially for the executive board. You never know what you're going to get for 1 year. The first male priori. Female priori. Suus Segers. We are going to draw a second and a third, because perhaps Suus might not be able or does not want it, so then we have a second option, but Suus is first. The second one, Floor Heubel-Moenen. And the third one, Monique de Jong. All 3 well known. Then we go into the masculine bag. The first one, Joachim Wildberger. The second one, Christian Wouters. As if they have nothing to do anyway. Huh? And the third one, Job Stoks. Cas, thank you very much. So this is now official. I will approach them next week and discuss with them the yes or no's of commitment to the CARIM Executive Board. I would advise everyone, if you're ever drawn from this bag, do it. It's a really nice experience, and then you know what we do, and that's basically not too much, because basically you do everything for us. So at least already thank you for your commitment, those 6, and then we'll continue with the last part, which is actually the most important part, the prize of prizes. Oh, basically I forgot a slide. For the ones that are interested, who's in the bag, you can see that here. That's now what we call mustard after the meal. Huh? These are all in the back, and the draw has already taken place. The prize of prizes, the CARIM Commitment Award 2025. It is an award for someone or a group of persons that has committed themselves in a true sense for our institute, and not necessarily scientifically, but also communal for any reason, at least having the spirit and walk the extra mile for our institute. And the committee is secret. The members of the committee are unknown, but it is rare that we put any recommendation aside. That has never happened. And this year, it's a very special person, and I have a little report. It was slipped under the door, and I will read it to you. And I hope the person is present, because like every year there's somebody not present. Today we celebrate a woman whose path has been anything but effortless. She fought for every step of her career, transforming challenges into strength and purpose. The journey shaped her into someone who works not for herself, but for a greater mission: the liberation of female researchers, the renewal thinking, and the courage to break with outdated values and norms. She brings new trends and ideas into our institution with remarkable directness and determination. Placing the cause above her own interest, she clears space for others to grow while pushing our work of CARIM into the future. Our communication is unmistakably hers, honest, confronting, yet always aimed at progress. Even when her words are sharp, they carry hope. Through her dedication, she has become a driving force for positive change. She embodies commitment, wholeheartedly, tireless, and deeply sincere. It's a privilege to honor her today. And I would like to call forward Judith Kozemans. She has to come all the way down. Yeah, that's the downfall of sitting upstairs, huh? She fainted. Judith, from the heart, because you care. Huh?
Dankjewel, Thomas.
Ja. Ja. CARIM-logo. Thank you. Hey, goed gedaan.
Dankjewel.
Alsjeblieft.
Ja.
So that concludes today, not before I have thanked my dream team, the ladies in the office who hit me every morning when I come in. It's a matriarchate in our CARIM office, you know, it's the same as with the bonobos. Well, thank you for not hitting me tomorrow morning. Thank you for all the efforts you put in this day. And thank you all for being here. For the next year, please register, because I love the extra amount of people that we have here today that did not register, but we walk into these logistic problems of not having or enough lunch for everyone that is here. So please, next year, register. If you cannot come, just deregister, we don't mind, but at least if you come here. For now, everyone that goes home, safe travels. For the rest, across the Vrijthof to Thyssen, and listen to the Thyssen officials. When they say the night is closed, please follow their advice and go to the door. And otherwise also, please not take any souvenirs from Thyssen, because last year we had some really big discussions about that. So behave as real CARIM people. And I wish you a lovely evening, and thank you everyone for being here today.